Vinegar. You are not born for 3D. You are born for 2D. The third dimension you need to add extra. Because so you can see the hydrodissection. See, normally I do only hydrodissection. I don't hydrodelineate. So I don't see the golden rings normally.
No, I have to be involved because Kannada.
KVS sir, if somebody is speaking from there, we get some moral support that somebody is there.
Yes, sir, we are here.
Because we are getting a.
Dr. Chitra is also here.
Oh, great, great.
Ma'am.
So you can tell her that we are just trying to demonstrate or trying to check the transition, the transmission part.
All well, sir.
Can you increase the illumination? None the normal chopper code. So this is actually a blunt chopper. I'm just going in, not really trying to do a direct chop. So you can see a lateral separation, at least breaks the 3/4 of the linear crack. Then separate it fully. Then this quadrant, this pi, I'm going to eat it up so that the mobility increases. Now I turn it again, turn it once again, crack it. So this is a slightly a brittle cataract. As you see, I have not really created an epinucleus. So the whole thing is the nucleus epinucleus complex is in one go. So this actually saves time and all the heartburn of the problems of epinucleus removal. There is no epinucleus here because I didn't create one. So normally we create our own problems as a rule in life and start solving it. So don't create your problems. So don't create an epinucleus. So now I have only a bit of cortex. So normally, customarily, since I'm putting an Alcon multi-piece lens of an Ocrasoft material, which is my favorite lens, even though they don't promote it well, multi-piece is my favorite, and it saves on many occasions a lot of trouble for us. It is one of the excellent stabilities, centration, and mostly in compromised states. In a bad capsulozonular apparatus, a multi-piece lens, your go-to lens. And many of the people have trouble, implanting the lens, especially beginners, because it is not as fluid, as safe as single-piece lenses like Clarion or an Acrysoft IQ. So now I'm going to implant a 3-piece lens. This is a small demonstration for people who are interested, especially the youngsters, like how to safely actually implant a 3-piece lens. So I'm going to, so if you can, I'll just take it out since we have time. So you can make out here it's a D cartridge. CL, 3-piece lens. Okay, to demonstrate, this is a D cartridge which has a 2.2 opening. So this is done for all single piece lenses, like all your Acrysoft IQ, Clarion, all the Panoptic, Storic, all those lenses which are single piece lenses can easily go through a D cartridge. But a multi-piece lens, because of its design, requires a slightly larger cartridge, that is 2.8, which is a C cartridge. So always choose C cartridge for a multi-piece lens and fill it up fully. And you can see it's an excellent material, time tested. For decades we have been using this. First put it along the orientation. The lens is little rigid because of the AC OT temperature, exactly like the way it is shown outside. This is your Monarch injector. So with the bevel down there, so you can see the lens is actually turning. So see the orientation. This orientation has to be corrected within the eye when you are implanting it, so that the leading haptic always is directed to the left. So now we start this. So this, I want you to concentrate on this. So once we enter, my haptic is turning to the right. So I turn by 180 degrees. The haptic start going into the bag, pointing to the left. So once it is there, you turn it the other way around. Can you see the lens is little rigid here, Visco? Nevertheless, it is in the bag. I have to now position it in a way that temperature ಸ್ವಲ್ಪ ಕಡಿಮೆ ಮಾಡಪ್ಪ, ಜಾಸ್ತಿ ಇದು 1 ಮಾಡಪ್ಪ H. So if you can ask me what is the one disadvantage of Alcon lenses is, in a very cold, if the AC temperature is very cold, the lenses harden. So they have to think of something to really warm the lenses before. So they don't like a cold reception, they need a warm reception into the eye. So now it is, I took the haptic optic junction and put it into the bag. So I use most of this visco removal with a single cannula before I go into the IA. Normally it is a good idea to remove most of the visco like this. So almost 80% of my AC is free from visco, only a little bit of visco is remaining. Now I go with my IA. Next case, ready? Yeah, here only.
Sir, also give us tips how to go behind the lens for others to know.
Yeah.
For that
Basically,
visco.
see here, there is already some visco behind. Now what I do is, for beginners, should go with the irrigation. So normally at the 90 degrees from your haptic, you can see all that my irrigation is trying to displace all that for lenses. You can rock and roll the lens.
You can rock and roll the lens.
And the very important thing is we are using a Lumira 700 microscope on this Ingenuity. The problem is you will never be happy with the clearance of the AC. You keep on seeing something or the other. Is hydro? See, normally if the microscope is not great, you will be happy that everything is out of the AC, all that muck, everything is not seen. But here with this retroillumination, normally you will still be seeing something or the other, and your visco removal will never get completed. So now I have concluded my surgery. I am doing the hydration. You can just check the intraocular pressure. It is good enough. 4 Quin. So this is the, I use a bit of moxifloxacin. We can probably discuss that later. So thank you very much for your kind cooperation.
Yes,
And
nice surgery, Dr. K. Krishna Prasad. Now, actually, the crowd is quite good here, so we'll start with Dr. Ravindranath. He's ready?
no, next case is here only. Next case is here only. No, so
Oh, we'll start with.
we are starting the actual
Dr.
case as per the agenda now.
Hmm.
This was actually a demonstration case just to check the communications.
Okay.
Okay, so we are going to start right away. I'll be, till that patient is put on, we can have a discussion about the technique that I followed, as well as the lens that we used. And also I'll be talking some details about the next case that I'll be.
Okay, fine.
So we can take some questions and discussions from the floor till the patient is shifted.
Sir, that's a 2D. I think sir is ready. Copy, sir.
Huh? No.
Next is 3D or 2D, sir?
That
Next
was
is 3D only. Next is 3D only.
Okay, sir.
The 2D will come after that.
that was a very detailed discussion, KP. I don't know what to ask you. You've told us all the answers for every step possible.
No. That is actually off the record. That case that was not basically in the agenda. That was just to check the
So
communication.
you have to deal this case in a different manner.
So, just for the beginners, the technique I followed. See, more importantly, most of the conferences are inundated by all the stuff about intraocular lenses, which should not be the case. Since most of the companies are interested to probably promote the lens brands, but as ophthalmologists, we should not lose sight of the major thing, lose sight of the main picture, that is the technique. The technology will always follow, but the surgical technique and what are actually the nuances of that particular case, we need to actually really be knowing. So in this case, it was a NS23, a brittle cataract. So I decided to actually do a direct chop. I didn't use a sharp chopper. The chopper was blunt, but little longer. So I just made a small, pocket in the hard central portion of the nucleus and just got a purchase on it. I really did not go deep into it and bury. That was good enough to actually go and crack the nucleus into two. Most importantly, the beginners are hesitant to actually crack the nucleus into two parts. So that's why there is a little bit of lateral separation and things always remain attached to each other. So you should know your zonule, you should know your capsule and try to crack the nucleus into two halves, at least 3/4 of the linear cut, if not fully. But in some cases where it's really a very hard cataract, a leathery cataract, you should actually volitionally try to separate all the layers, especially the posterior plate, so that you get nice two good heminuclei. Even if you don't really complete it, it is fine. You can still rotate the nucleus, cut another pie and remove it, more importantly. There are people who cut the nucleus into multiple pieces and later start removing it one by one. That is a great idea.
So we really like the way you made that small trench so that you get a better purchase into the meat of the nucleus, and also appreciated that it makes sense to take out one piece because you are creating more working space in the bag. That's how I would also prefer to do it. And then it becomes very easy. All the fragments get loosened out and then you are able to just eat them up. So that way, it's besides the excellent fluidics which your machine has, these techniques help to ensure that you're very power efficient in your surgery.
And
That
Dr.
was
Chitwal,
good.
I wanted you to actually discuss about with the crowd, like your go-to situations for a multi-piece lens. Here I showed a multi-piece lens
Yes.
and the intricacies of it.
Yeah.
So when do you actually prefer to use a multi-piece lens in a routine situation and one in a contingency? Can you take it, Amma?
See, multi-piece, these are, to be honest, these come as different packages. So multi-piece lens and single piece and all that. The multi-piece is a very versatile lens, which gives you the kind of quality nearly as much as the single piece or on par with it. But the important thing is, if you've had a PCR, and those are the moments when this three-piece lens makes you realize what a big boon it is, because you can actually place these
Girish,
three-piece lenses on the
using blue
sulcus.
filters.
And if you can do what is called an optic capture, that is,
Capture
after
the
having done a good
blue,
vitrectomy,
so you can
keep
use
the haptic on the sulcus and just push the optic through the rexis into the bag. So in this situation, you don't have to make any calculation, change of calculation. Whatever was planned for the single piece, the same IOL part can be used for a three-piece if you're going to do an optic capture. So besides just being placed in the bag, the three-piece gives you this extra advantage of being used in a situation of a PCR, which sometimes is it's a pre-planned thing or it's an unexpected thing. In a big eye, no, also a three-piece lens comes as a big advantage if there's a small subluxation in a small area,
Details of this
just
case.
one claw card. Even if you would like to place a CTR, these are places where you should place your three-piece and ensure that the haptic of the lens is placed in that region of that dialysis. In other words, the CTR is buttressing the whole capsular bag over and above the haptic of the three-piece is also pushing the dialyzed portion away. So these are some extra
Light
steps
trimmer?
which further ensure that the bag is centered and there is no vitreous herniation happening through that area of weak zonules. So that is one other place
Like this.
where a three-piece holds an advantage.
Light nodema?
Again, if a three-piece is
Correct,
being
Anna.
placed, if you've had a Rexis extension, you should ensure and you are planning to keep a three-piece IOL. Ideally, it
Light
makes
nodema?
sense to place a single piece in the bag if you have a choice in the case of a Rexis extension. But if if you have a three-piece IOL, you should position the haptic of the IOL away from the area where there has been a Rexis extension. So dial it in that kind of position. And you had wanted to ask for?
Good morning, everyone.
Uh,
Uh,
Can we
so-
have the details of the case?
Yes, sir. The case that is going to be done now is a right eye cataract surgery of a 52-year-old female. It is a mature cataract with the vision of perception of light positive and projection of rays accurate. The fundus view is not visible. The axial length is 26.15 millimeters and the IOL power is plus 14.50 diopters. The lens that we are going to be implanting is Essence IOL from Aurolab. Over to you, sir.
Uh, So I welcome once again on behalf of MM Joshi Eye Institute Group to the iFest 2025. See our annual academic extravaganza where we have the surgical ophthalmology as our theme. And we are known for having live surgeries, which a lot of deliberations happen. And I want every live surgery to really go away with some takeaway messages for the surgeon as well as the people audience out there. And I do the moderators will do a great job. So I'm starting officially our the live surgical sessions of the iFest on day one. So this is a case where you know that already we have a nuance here that it's an intumescent cataract. The lady is slightly on the myopic side. The IOL power is around 14. I'm using an EDOF lens for her, which is an Aurolab Essence. And the plan is to have, it is an intumescent cataract. You can see the entire lens is swollen. The lens thickness is almost 4.1. And now my job will be, the lens looks slightly now on the softer side. So my idea is to basically have a proper Rexis. So we can have discussions on how an intumescent cataract can pose problems for a Rexis. And in case if it runs away, what do we do next?
No.
And-
Why, before you do your Rexis,
Yeah.
would you pre-operatively do anything in a case of an intumescent cataract, more so if it is also going to be a small eye? Would you consider anything in the pre-operative placement? Like pre-operatively, I would say if it is a small eye, I would like to decongest the vitreous also. So I might consider giving an oral glycerol if the AC depth is going to be smaller or a higher IOL power is going to be used. And there is intumescence also. Do you think it is too much of a kill, or would you also think of it in a small eye?
Okay, there are two things here that you have told actually, Dr. Chitra. One is about only the intumescence. In a normal eye, in a normal eye, an intumescent cataract is basically you need to look at an idea about the lens thickness. Now we have with Anterion and all the anterior segment imagings, you can actually assess the lens thickness and also know how much is the cortical waterlogging. Okay, so this is important. The whole idea is to flatten the dome and also to get. So there are multiple ways to handle this situation. And the idea is, of course, you need to stain the thing. I don't normally stain my cataracts, except white cataracts. I don't stain normally because most of the retro glow in all our microscope that we use is usually good enough. And as a policy, I don't stain cataracts which are not white. And somehow I never get a good staining of the capsule. I don't know. Okay. So if you can see, this is at the same time, let me also reiterate that this is the first ever demonstration of the new version of the Ingenuity 3D visualization system. We have that Ingenuity 3D visualization for many years. We were the second installation in the country after RP Center. But this is a new version. They have now come out with a lot of refinements, especially for even anterior segment surgeons. So this is the capsular clarity mode. You can actually see the capsule so well. See, now the technique of how to handle this intumescent cataract. I've just filled it with the methyl cellulose only. There are many ways to skin the cat. There are 20 minutes and 30 minutes presentations on different techniques of how to handle an intumescent cataract. So mine is the simplest one. I use Viscoat, which is supplied from Alcon. I just put a premium viscoelastic and fill the eye with it. And I do my normal simple cystotome. You can use the main port or you can use the side port, whatever it is. So I use only Viscoat to buttress the anterior capsule and get my Rexis using, I'll definitely use an Rexis forceps. Light note, Tirima. I go to the center.
Would you consider not going to the main port and the
Yes,
side
yes, yes,
port
definitely.
instead?
That is the very important message. But here it's not very ergonomic, so I did not do that. So Viscoat. So I just started my curve. So for completion's sake, I'm going with a thick irrigation cannula. So you can see actually there is a tear on the other side, which I have to now tread very carefully. Now the stair which is extended, I have to go beyond that because otherwise I'll end up with a very small Rexis. And I only rely on my viscoelastic, that is Viscoat. Oh, this. Now again, now I pull it centripetally.
That was very nice, the way you showed, the way he pulled the Rexis towards the center and then away from the area of Rexis extension. Very beautifully managed. The only small thing I would differ is I would never go to the main port. I would go only to the side port. And he's a great surgeon. He's managed to get ahead with a good Rexis in the right way. But with intumescence, I would somehow prefer to start with a smaller Rexis and then enlarge it.
Okay, that's fine. That's another well taken point, ma'am. So like I told you, only the side port was the way I'm sitting, Tyler, was not very ergonomic. So I went to the main port. Otherwise, I would rather do this. And I'm not really used to doing Rexis through the side ports. So now the rest is probably a very simple thing because it appears to be a very soft cataract. Can you increase the illumination? Can you have the tissue clarity mode?
KP, this is a myopic case, I believe.
Yeah, yeah.
Any phaco parameter changes, especially when somebody is operating on a basic phaco machine?
No, basic or advanced. Basically, you don't want too much of fluid to go in because they have a low scleral rigidity. The chances of AC becoming very deep are there. But since it is not a very high myope, I'm not really altering my IOP settings. The IOP settings in a Centurion machine is an excellent tool where you can actually have a lot of control on the fluidics. Oh, I want the retroillumination. Sorry. Retroillumination. So I forgot to switch on the retroillumination because we were in the capsule mode. I continued. Otherwise, Okay. So you can probably appreciate the surgery better now. So actually, this is a softer cataract, but let me reiterate for the beginners that a softer cataract is actually a bigger problem than the harder cataracts. The more denser cataracts are easy to manage with, especially with higher end machines. So than the soft cataracts, because in that flurry of excitement, you sometimes go through the soft cataract and the epinucleus and damage the posterior capsule. And especially with the machines like Centurion, which has the Ozil technology, the cutting is so good that if you don't really change the parameters or if you're not mindful, you can actually go through softer cataracts like a butter and get into trouble. So you should be very careful in trying to control your excitement as well as control your parameters. So most of the people who start beginning with the Centurion machine can get into trouble if you then really are not mindful of this, especially the ultrasound part of it.
This case being a milder myopia, you've kept your IOP at 60. When would you want to, what kind level of myopia would you bring down your IOP?
No, actually, this is only 14. Actually, the axial length is only around 25 plus. It is only 14.5. So if it were to be a high myope, like especially at more than -10 myopia, or if the axial length more than 26, I would normally work at 40. Normally, I'm a high IOP person,
Yeah.
even though there are a lot of.
It is an individual comfort. I agree.
And I really think that it doesn't really matter much in my case. So this is the Orolab Essence. This has been my favorite lens. I've used multiple times and I've got a good result, especially on binocular implants. So here you just take it out. You can see it's a preloaded lens. It's a preloaded hydrophobic acrylic lens. Normally, I take a little precaution in these lenses to put some visco underneath it. Can you see below the optic? And try to actually move this and see that it's mobile. Then and see that no part of the optic or haptic is outside the reach. Then you can push this in and take this cap out. And additionally, I normally put this visco from this side also. So you can see the lens inside, nicely ready, getting folded. It's a very smooth lens, and I've not enlarged the section. It is same section, 2.8. So I'm also using a irrigation, trying to do it's not a completely a hydro implantation. I told you again, it is the OT temperature which is a problem here. The lens is little on the harder side here. I think the surgeons out there have to discuss this point somewhere later in the day to decide how this OT temperature actually changes the lens physical characteristics and its the way it opens up. So because it really takes some time taking the warmth of the eye to really open up again and properly. So here you can see that my rhexis has gone to the periphery, but the rhexis is intact. Nevertheless, this was a case where. So I'm removing the visco again here. So are we ready at the 2D and OT1? Okay. So I bid adieu to all of you to leave the OT to Dr. Atiq Sheikh from Chennai, one of the rising stars of ophthalmology of South India. One of my favorite youngster. I see a lot of promise in him. He's actually operating on a 2D in our operating room 1. And I leave this OT to you.
This Essence lens, besides being a preloaded, Is there anything specific about this lens? We have not used it, so.
Okay, see, Essence is a wonderful EDOF lens from Aurolab. And you know that Arvind have a very high scale of operations and they have done, especially Dr. Shivkumar from Tirunelveli has done a lot of studies, thousands of lenses have been used. I am privy to personally have communicated with him and they have got a very good result and this is one of the very cost effective EDOF lenses that you can think of,
EDOF.
especially on a bilateral implant. And if you really patient wants to really read even a smaller print, maybe a micro monovision or making around 0.5 myopia of one of the eyes can actually really help a lot.
You
So,
would call it an EDOF lens or would you relate it to the eye-hands group? Enhanced monofocal like that, is it?
okay, it is more like an enhanced monofocal, but you can probably, for simplicity's sake, I call it like an EDOF lens. So, not strictly speaking. So, I think it's time to shift to the OT1. So, Dr.
I think we
already.
need to give a good clap to Dr. KP for the wonderful demonstration and explanations along the way.
Yeah.
Thank you.
Thank you so
KP,
much.
very nice surgery. Now, before we go on to the next case, I request Dr. Chitra and Dr. Arup and other panelists to any tips for white cataract that you would like.
So thanks, Satyamurthy, for asking me to contribute. See, if it is a white swollen cataract with a very shallow anterior chamber, then I would give a pre-op IV mannitol, about 250 to 300 cc, 20% IV mannitol. So that not only dehydrates the vitreous, it also dehydrates the lens. And then staining, actually, KP is of course a very gifted surgeon, but you want the central part also to be stained well. So if the staining hasn't gone on well, then I would re-inject trypan blue into the anterior chamber and wait for another 5-10 seconds for a very uniform staining of the anterior capsule. And now in certain situations, like you have intumescent cataract, small pupil, you have done the staining and then you find that, once the pupil is dilated, only the central 3-4 millimeter of the central capsule is stained and the periphery has no stain. And then you need to stain the periphery. So in that situation, I would not use a soft shell technique straight away. Normally I use a soft shell technique. What KP had shown, use a dispersive OVD, inject it, and then inject, a cohesive OVD just in front of the capsule. So I would just be using a cohesive OVD because if I have to restain the anterior capsule and if it is dispersive OVD which is there in the anterior chamber, it is very difficult, it is very time consuming to remove it for you to restain the anterior capsule. So then I would defer the soft shell and use only, Hilon or Hilon 5, Hilon GV to form the anterior chamber and then if restaining is necessary. And
Maybe,
KP showed a beautiful demonstration of, the Rex's, Brian Little's Rex's retrieval. Actually, Brian Rex, his retrieval technique, is a little different, because everybody modifies his own technique. He comes from the paracentesis incision, grabs the capsule at its root where it is going to run to the periphery. And instead of pulling it radially towards the center, he pulls it in the opposite direction. That is, wherever the rexis was intended initially, you pull it 180 degrees away. And this is what I also do. So that way, you stand a greater chance of retrieving the rexis, which is running to the periphery. And once you have given a new direction to the rexis tear, then you use a centripetal force and then control the rexis. I think these would be my tips. And many of these intumescent cataracts are quite brittle, as you saw here. So you don't really require that much of expertise with disassembly. But some of these patients may have may harbor a very dense brown cataract with thick nuclear plate. In that case, of course, it's a different ball game. I'm sure there'll be some demonstration of soft, hard cataract disassembly strategy. But KP, you're a master surgeon and you have done extremely well. And regarding the IL implantation, I do not, see, I am not really fascinated by a preloaded lens because if a preloaded lens comes out and you're always on your toes, how the leading haptic going, why is that opened up, and the trailing haptic, it doesn't come out easily, it doesn't open up once inside the eye, and you have to wait for some time. So I sometimes would feel that until unless a particular lens has really got established in its preloaded technology, I'd still prefer to use a lens which I load myself. and it gives me greater control. Of course, there are good lens delivery systems where things go on very smoothly. And slow unfolding basically is, what I do is I keep the lens packet on the microscope, on the microscope body. So because of the bulb, the lens also stays heated. It doesn't get chilled to the OT temperature. And just before the IOL implantation is taken out and the IOL implantation is carried out. But that's not foolproof. Even then I have noticed very slow unfolding in certain types of hydrophobic acrylic lenses. Thank you.
Wonderful tips by Dr. Arup. For a small pupil, instead of restaining it, what I would do is, I would go behind behind the iris and inject Trifen Blue so that it stains that part of the anterior capsule which is hidden by the iris. Because you may plan to put iris hooks and then create a larger axis or enlarge the axis, and that becomes difficult if that part of the capsule is not stained.
So can I tell you the other part of the story?
Yeah.
Yeah, yeah, I mean, yes, and there are some points later on.
Thank you so
Sarab,
much
I
for
think
the
since
valuable
treatment is on the
tips.
table, we will start the surgery.
Yeah.
Dr. Atik Sheikh Hamid from Chennai will be starting the surgery. Over to you, Dr. Atik. You are on mic.
So this is a left eye cataract surgery of a 77-year-old male. It's a senile immature cataract, and the IOL power is plus 20.5 diopters. T3 EMB toric IOL is going to be implanted. I once again just welcome all our panelists for the live session. Dr. Arup Chakrabarti sir, Dr. Chitra Ramamurthy ma'am, Dr. Shankar Gowda Patil sir, and Dr. Mahesh Bhajantri sir. We also have with us Dr. Sunil Biradar sir, who has just been appointed as the supervisor of the Karnataka Medical Council. We welcome you, sir. Over to Dr. Atik Sheikh.
Yes. So this is a 2 diopter patient has got a 2 diopters of corneal astigmatism. So we are using a T3 EMV toric IOL. So I'm operating on a Centurion phaco machine with the Luxor Rivalia microscope. The glow is quite a hard cataract. The glow is quite good and amazing. Just to ensure that my visibility of the capsule is better, I stained it. The marking has already been done. A slit lamp based marking is done. However, this comes with the overlay also.
So this surgery is being done on the Luxor Rivalia microscope. That is the LX3 from the Alcon group again. So they were not into microscope so far, but now they have come out with a very blockbuster product. And we have been using that for some time, and the kind of retro illumination and the kind of you can play around with a lot of illumination systems for all situations. So this microscope pen has been a very useful tool in making our ophthalmic surgeries much easier nowadays.
Very nice Rexis, Atik.
Thank you, ma'am.
Dr. Chitla, you are comparing with the previous case, no?
No, I'm not. You did very well. Don't be fishing. Only thing I'm worried when both of you guys go from the main port, because I somehow feel that Rexis should be done to the side port with the main wound closed.
No, completely. Can't agree more. This is definitely the point I told you last time, because I was working on an Ingenuity system where the camera is slightly off center. So wherever I was moving, there was a spatial disorientation because the camera is slightly set upward. That's why I said I'm not going to the. Otherwise, this point for youngsters is well taken. It's always better to have a deep AC, not to lose the viscoelastic. So side port Rexis is the way to go. Dr. Chitra's dictum.
I'm not getting power. Yeah. No. Yeah.
Parameters. Ravi. Ask him to show that.
Hello, KP.
Yes,
Centration,
okay, sir.
it's not well centered.
Okay.
The patient has moved his head. 1 minute. Yeah. Can you move it?
So
Can you
as
move
you
it?
can see, he's not using any torsional.
Can you move it?
He's
no.
using longitudinal only now. So a lot of people do
Fine.
that, use the longitudinal to the great advantage in even in Centurion machine.
Can you move? No. Yeah. Can I have some saline on the cornea? Can you reduce the power?
Can it be shown on the main screen? Because some of the parameters are not visible.
Epinucleus mode.
You're telling this one.
IA.
Tell them.
Sir, irrigation is not working. Yeah.
Dr. Satyamurthy, any comment about the technical team wants to know about the clarity of the present, video there?
There was a drilling sound which was coming while he was doing emulsification. It's not routinely heard. It's not to do with the very high power.
No, that because he was not using torsional, he was using longitudinal. So on Dotto, it was a pulse mode. So that was the sound. Normally, we may not be using the pulse mode longitudinal most times using Centurion. So that is a sound that they normally have. Can you comment about the video quality?
Video quality now is good.
Okay.
IA.
Where is that small
Increase the
epinucleus fragment?
coaxial is 100%. Increase it.
And small PC rupture, sir.
No problem. You tackle as it requires. On this side. If you plant, anyway, I'll take over the side.
knife, keratome. Keratomes.
Get the IPC already there, we'll switch. So he's implanting the EMB toric lens from Rayner. The Rayner has been an associate of ophthalmic care from the time of Dr. Harold Ridley. The first ever IOL that Dr. Ridley implanted was basically manufactured by Rayners. So that is the kind of association that we need to really remember with gratitude. The Rayner, which really has stood by the side of ophthalmologists. They continue to give supply very good lenses, and the Rayner model, these two haptics which are joined at the tip, has been a runaway success, and most companies have followed the Rayner model. So since it's a EMV toric lens,
Reduce the
Dr.
flow,
Atiq Sheikh is
reduce the
aligning
flow
the
and
lens
vacuum.
as per the intended axis. Where is the sheet? Toric sheet. Can somebody connect there? Switch to this. So as you can see, it is aligned at 178 degrees in the left eye. So this has been the toric planning, and
Side port knife.
the patient had a flat axis of 44.85 and a steep axis of 46.56, nearly 1.6 diopters. So it's actually against the rule. So the eyeball is being aligned at 178 degrees in the horizontal meridian. So it's a T3 model. So it is called as 210T3.30. So it's a T3 model which is covering at the corneal plane 2 diopters of astigmatism. Can we switch? Switch to, switch. Sir. सर अभी हाँ नहीं सर, जैसे आपकी वो लेंसेस करके रखेंगे तब तक। तो now एक IPCL है, उसके बाद तब तक एक उधर एक इंजीनिटी होगा सर, उसके बाद आपका होगा। सो आई बाय देन come in the morning. This is 2D, sir. And this being projected. See,
I think the hand piece blocked, yeah.
switch.
Yeah.
Switch.
Thank you, Dr. Atiq. Very nice surgery.
Thank you, sir.
Yes,
Thank you.
nicely displayed.
Shilpa ma'am,
Yeah, am I audible?
your mic on.
Yes.
Okay, yeah. So good morning all. I'll be operating an IPCL lens, phakic IOL by Care Group.
No, Dr. Shilpa, just wait. Somebody, yeah.
Okay.
So the next case that we have is a 25-year-old male patient, and we'll be performing a right eye phakic IOL. The power is 27 diopters with a cylinder of 2.5 degrees at 100, 2.5 diopters at 100 degrees.
At this point, I make sure that there are not many air bubbles in the cartridge. So this is the lens if you want to. Yeah. So I guess you all can see the lens. There is a central hole, centraflow. There are another 2 holes superiorly. This should be coming up, and there are 3 plate haptics. And this is the toric marker. Is it clear?
Yes, it's clear.
Yeah.
We also need to ensure that the convexity is up.
Convexity is facing up, yes.
Yeah.
And then I try to put one edge beneath these slots and then put the second one. It is very easily moldable lens. Unlikely to its contemporaries. One is very soft and another are very hard lenses. This is pretty malleable lens. I push, and then I close the plate haptics of this butterfly cartridge. And then this is locked. After locking, we must check that the lens is not stuck anywhere. So after the smooth movement, we move to the case. Mallikarjun, light nodi. Very good.
Can I-
Open ಮಾಡಿ.
You can increase the illumination.
This is the most maximum illumination, ma'am. Or else I'll have to wash. I'll have to put on to retro mode.
It's fine.
Wash. Okay. Mallikarjun, light nodi. Okay. So I prefer marking 4 points. I start with a side port incision. I don't get a full pass entry of the side port incision. Yeah, better. Yeah. So this is a tissue detail mode. So this gives you more illumination on the screen.
You should inject enough viscoelastic, but not to overinflate the eye. Because you don't want the pupil to be too dilated.
Light note, Mallikarjun.
Because tucking in of the haptic is better seen with the pupil a little smaller.
Yes, as you
And-
said, ma'am. Once I make a incision, then I do an aqueous visco exchange.
Make a 3 mm incision.
2.8 millimeter. And I start injecting. If I see the bubbles, I don't inject the lens. I get them out. And then I start injecting the lens. So once I start injecting the lens, it is very important that there is a small jerks to the lens. And it is very important that we focus onto the small knuckle that you can see that might open onto the left side.
Left side.
Yes.
So we need to use our wrist to rotate the lens so that the landmarks are seen. That is that left knuckle, the knuckle on the left leading side and on the right trailing side. That's a very important thing. And also those 2 holes should end up getting superiorly located. It's parasite.
Light nodi. Okay. So always, whichever eye it is, the left leading haptic should see that knuckle. I prefer putting or tucking the trailing haptics first because that takes off some of the viscoelastics out beneath the lens, and then I can top up the viscoelastics over the lens. So I really don't have to struggle taking off the viscoelastic substance from beneath the phakic aisle. Light node, diary, light. Can I get badi Mallikarjun? Light node, please. Visco. So at this stage, once the bubble is out, then we can see all the details of the toric system. And here I do adjust the lens. I don't like to manipulate much the lens once it is behind the iris.
And you should also look for this iris, iris there, the periphery. The roundness of the pupil is a clear indicator that the haptics are very well in the sulcus. Rarely, if the pupil is not really looking round, you should consciously go back to see whether, and you have to always press the haptic at the haptic optic junction and then push it behind the sulcus.
If you have lot of viscoelastics, what happens is your haptic keeps on rolling, and then you cannot light nodi Mallikarjun. Talag nodi Suru. You cannot insert these haptics beneath the iris.
Sometimes if this pupil is too dilated, you can burp a little visco out by pressing on the lip of the side port, the main port. Then the pupil becomes a little more smaller, then you can very nicely visualize the haptics well positioned in the sulcus.
Yes, ma'am. Very important tip, ma'am. So now I guess it's done. Now only the thing that we have to be very, very careful is not to have lot of fluid that goes suddenly. There should not be sudden flowing of the fluid in the anterior chamber because that will extend the sclera and it will be painful to the patient. So I make sure that I burp little bit of more visco before I go in through the side port to aspirate the viscoelastic substance. I am not very close to the lens, but I am in the mid AC so that the fluid currents are not hitting the anterior capsule. There should not be very heavy or current fluids passing near the anterior capsule, which may lead to development of early cataract. A very important tip.
So you are working on the 3D IOCT microscope.
Yes.
So in this, you can also then show what is actually the vault of the lens by focusing.
IOCT.
So you can actually make out what is the distance between your IPCL or ICL phakic lens and your crystalline lens.
Yes. I'll just ask someone to switch on the IOCT. There was some upgradation going on with our IOCT, intraop OCT. I'll just find out whether it's done or not. If it is done, we'll be showing
for the next, maybe for the next case. But then, you know, this is very useful if you have intraoperatively and if you know that your vault is high or your vault is low. And almost always 80% of the times it will be correct if you compare it with the post-op vault that you see on the anterior segment OCT.
Yes, ma'am, but
again, we saw her handling, removing the viscoelastic from the main port, like she's done it very elegantly. But I think for a beginner, it's better not to go to the main port at all. You don't want any AC shallowing, so always keep the main port closed besides inserting the IPCL and go do all your maneuvers, even tucking the lens, everything through the side port itself. So that would ensure that the AC is constantly deep because neither do you want the ICL to touch the back of the cornea, nor do you want any shallowing that does the lens touch. That is the most important step during the entire procedure to be observed very carefully. Dr. Namrata, would you ever consider doing a hydroimplantation of phakic IOLs? I somehow don't, but I just wanted your thought on it.
So I think people are doing hydroimplantation, and the advantage is that you don't have to aspirate out the viscoelastic at the end of the surgery. but I'm also comfortable doing it with viscoelastic in.
Ah.
There's no big deal. Viscoelastic can always be aspirated out. Also, I think
ಹೌದಾ?
the people also like to aspirate from the central
ಯಾವಾಗ
port,
ತಗೊಳ್ತಾರೆ
which was
ಅಂತ
not done in this case.
ಹೌದಾ?
So you can take your irrigation
Already
aspiration
passed, sir?
probe off the phaco probe and actually put
Mostly ಅಂತ ಗೊತ್ತಾಗಿಲ್ಲ.
the aspirating tip onto the hole which is present centrally and can aspirate the viscoelastic out between the phakic lens and the crystalline lens.
There is, that's a very wonderful tip which she's told us, and I think we should remember all of this. The other thing which of late, for few years, which I've started doing is I keep the pupil undilated, and on the table I inject phenocaine after I make my incision, because that step is again a very important part where you should not, your instrument is a little blunt, you should not inadvertently touch the lens by any remotest chance. So the undilated pupil, I would make my incision. And of course, this is an individual choice. I would prefer to use heel-on because evacuating the viscoelastic becomes extremely easy. You have any particular
So, phenocaine,
Right
we
now.
are using nowadays
Medical
routinely. But yes, when we started to use phenocaine, there was always a fear that how it is going to, what are going to be the interactions vis-a-vis a
Yes.
crystalline lens, which is clear. But now having done it in thousands of cases, I feel that phenocaine does well, especially for phakic IOLs, because these patients are young and the pupil is dilated, the lens is clear. And for them to look at the light, operating microscope light, it gets a little tricky. So they tend to, move their eyes or tend to be a little photophobic, not photophobic, but they tend to blink their eyes. So once you put phenocaine, not only the pupil dilates, but it kind of anesthetizes them also. So the eye movements will be much less if you put phenocaine.
So this is a wonderful phakic IOL. Only thing we have to be conscious of the landmarks, which is very critical because, and you should do a slow unfolding of the lens so that you are, even if the lens landmark are such that the left bump is going to come on the right, you can, with just a gentle twist of your wrist, you can reposition it. So that is so important. Don't inject it like you would a regular IOL and push it totally. Slowly let it unfold so that small micro adjustments can be made so that you finally position it in an appropriate fashion. Because any other manipulation in the eye of turning the lens upside down should never happen in the AC because these are young lenses. So we want the lens to be transparent. If such a thing happens, then you should be prepared to get the lens out and reload it and insert it. And you should never increase the size of the incision when you're going to get your phakic IOL out.
Yes, ma'am. Thank you for the wonderful tips, ma'am. Namrata ma'am and Chitra ma'am. I guess our next surgeon is ready, Dr. H.M. Ravindranath sir. We'll be moving on to the next case. Thank you all.
Thank you, ma'am. I once again welcome our esteemed panelist, Dr. Namrata Sharma, ma'am. We move on to the next case. It's a left eye cataract surgery in a 74-year-old female. She's a known case of diabetes mellitus and hypertension. The visual acuity of the left eye is unaided 6/36, not improving. It's a hard cataract with nuclear sclerosis of grade 4. The fundus was normal. The left eye axial length is 20.66 millimeters. And the IOL power is plus 23.50 diopters. The IOL we'll be implanting is the Synergy IOL. The operating surgeon, I move on to Dr. H.M. Ravindranath, sir. Over to you, sir.
Before he starts, I welcome Dr. Ravindranath to the OT, one of the prolific phacosurgeons and a real comprehensive ophthalmologist, pan-ophthalmologist of Central Karnataka. So he will be operating on the Luxor Rivalia microscope and he will be actually using the Centurion phaco machine and implanting a Synergy lens from J&J. And Dr. Ravindranath is actually operating a hard cataract. He is going to now show what are the surgical techniques of managing a hard cataract, which is so useful for the beginners in phacoemulsification. Over to you, sir.
Thank you, KP. When I started this case because in RP Center, juniors were preparing for seniors. Today, KP prepared the case for me. So, some sort of taking revenge.
So it's a reverse deja vu, huh?
Good morning, Namrata ma'am,
Good
Chitra ma'am,
morning, good
and
morning.
Shankar Patil Garu. This is basically a grade 3 to 4 cataract but because of the good microscope and good glow, it appears softer. Sometimes these good microscopes misguide the grade of cataract. Better to see in slit lamp before you grade the nucleus. So I am taking a clear corneal 2.8 millimeter tunnel.
So I think you're quite right. The current day microscopes are such that the
Yes.
glow is really very good, although the cataract is harder than what the glow
Yes.
suggests.
So I do a side port.
And also if it's a myopic eye, then also the red
Yes.
glow would be much better than, would appear much brighter than
When I-
the.
When I'm doing my left hand side port, I try to be little only a small this thing around less than 1 millimeter, because what happens during phaco, if you do a full side port, but the fluid leaks from through that side port because chopper is thinner compared to the eye handpiece. So initially you can do a mild opening, then you can increase. This is Acular, no? Yes. Visco. In harder cataracts, what modifications we can do is, one is we can give block because not that hard, so I just continued with topical. The second change is stain if the glow is not good, but here glow is good, so I prefer not to stain this. I can manage without staining, but for beginners, or if you think glow is not good, better to stain. This is the second modification of a hard cataract. Third modification is doing rhexis. Adequate rhexis is must, but at least don't do a smaller rhexis because nucleus manipulations will be difficult, and sometimes you may have to go to periphery to take the chopper. So you may damage the capsular rhexis margin. That's why it's better to retro idala? Retro. Okay. Yeah. So I'll do a little around, I'll go Salim. Little like around 5.5 to 6 millimeter axis. Yeah, I think now axis is adequate. So axis margin is not that clearly seen. I think now it's better. I should have probably stained it anyway. So doing hydro in a hard nucleus, a minimal hydro is enough because there is no big space between the nucleus and cortex. So I usually try to negotiate with this thing only, with my hydro cannula only. My initial rotation will be with the hydro cannula only. And once I'm comfortable, then I can probably complete dialer. Then I will complete the dialing with rotation with the dialer. So if you remove the adhesions between the cortex and the capsule, then your cortex removal becomes easy. Okay. So, and the fourth modification of a hard cataract is I slightly retract the sleeve and the exposure will be little 0.5 millimeter more than normal cases because the nucleus is thicker in the center and the bury will be adequate if your exposure is more. That's why I usually, and the fifth modification is the chopper. I usually take a long sharp chopper for hard cataracts. Light nodama. Aramagiri, okay. Okay. So initially what I'll take out this epinuclear part. So that you know exactly where the nucleus is there. Chop tama?
You can see how hard the cataract is actually, and the red glow was suggesting otherwise. What is the power of the lens that we are going to use in this?
ಎಷ್ಟು power ಎಷ್ಟು? So I just trying to.
So how much you must be, how much phaco power you are using? Can somebody tell from the OR? The power that is being used, although we can see it here, but it appears to be a little.
So see,
Non-
because the harder nucleus, the posterior plate is still intact.
Yeah.
So that is very important when you should always posterior plate should be broken completely. So in harder nucleus, this happens, the posterior plate. So now, yeah, this is slightly posterior break.
And it is leathery also at the back.
Yeah, yeah. So I am trying to, the another modification is making as much as more pieces. So this is the endonucleus, probably you can take the endonucleus and emulsify it in between so that it will create some space. I'll just separate the posterior plate so that my this emulsification becomes easy. Yeah, this is a, I'm sorry, it's a multi-level chop you should do because you have to separate the pieces. Yeah, I think pieces are almost separate now. Go for quadrant now.
Yes.
So in between, what we can do is we can just, because it's a hard cataract, viscot. There's one more modification. In between hard cataracts, always supplement the anterior chamber with the viscoelastic. So to protect the corneal endothelium. The ozil is a boon in this type of cases. It protects the corneal endothelium. The thermal energy produced is very less. Quadrant ಹೋಗ್ತೀನಿಗ? Yeah. So making small pieces. And rotate it so that it aligns with the phaco probe. Even the nucleus was appearing so like moderately hard. Now you can see the grade of the nucleus is really hard. And the beauty of the machine is even with the hard nucleus, it cuts without any problem.
The beauty of the surgeon is also there, HMR, managing such a hard cataract, showing in a live surgery and doing so well.
Okay, let's go.
I think very well demonstrated, and it
Yeah.
was really a very hard cataract.
Mm.
So you can hear the claps for you.
Thank you. Only thing is, see, you can see with the side port, there is slight sharpening of the iris here because it was a sharp chopper. So the thing is, another one thing is most of us, we concentrate on the phaco tip. We lose the concentration on the phaco chopper. So that's where you damage capsule or you damage the iris. Sometimes you damage the zonules. So that one thing you should take care. See, that's why cortex. So hardly there is cortex in this case because it's a harder cataract.
Ravindranath, this is Arup here.
Sir,
Usually hard cataracts elicit a lot of discussion,
oh.
but here we are rendered speechless. You've done so well.
Very thin cortex left behind. Okay, take this thing, 2cc code. There is a small cortex here. Sometimes what I do is I go with the side port, opposite direction, just yes, flush it. Yeah, this is one technique where if you're scared to touch the thin cortex, so that you may damage the capsule. So just flush it the 2cc and you can see. This is called Ravi Kulkarni technique. This is my junior Ravi Kulkarni. I learned from him. A penuclear wash and cortex wash with a flush irrigation.
The posterior capsule can be, some of it which you're not able to peel off from the PC.
Yeah.
You could do a hydro wash and remove
Lens,
it.
lens. Hydro ಮಾಡ್ತೀನಿ. So now eye is ready for implantation. This is MTech cartridge with Synergy lens. You can see the MTech cartridge with Synergy lens. It's not a preloaded lens. So I just do scholastic. Okay. Orientation correct, Adala? Okay. Synergy is a beautiful lens where it takes the advantages of a multifocal lens and the EDOF lens, removes the disadvantages of both the lenses. So you have near vision N6 at almost 33 centimeters. It's a continuous range of lenses and works well in even low contrast. The violet filter capacity reduces the glare, especially nowadays the lights are LED lights. So it's a good lens. I implanted good number of Synergy and quite happy with it. And except professional drivers, you can use this lens in all, even male patients. Because this glare and halo issue is not there, not much. I don't say it's not there, but it's not much. Fog is a fog. Irrigation. Irrigation. ಅದು ಕೊಡು ನಾನೇ ಮಾಡ್ಕೊತೀನಿ ಕೊಡ. Okay. So I'll do a hydro implantation of this lens. Light ನೋಡಿಮ್ಮ lens ಹಾಕ್ತಿದ್ದೀನಿ. Okay, so the advantage of hydro implantation is you don't have to wash the viscoelastic. So the how lens beautifully unfolds there, good there, yeah. Probably this is the again KP was morning, he was telling temperature effect. I don't know.
Very nice demonstration of hydro implantation. Only thing, all the lenses are stiff today.
Yeah.
Do you routinely be doing hydro implantation in all your cases or?
Except 3-piece lens, all my cases are hydro implantation, madam.
Oh.
So that like, especially toric lenses, it's a very good
Yes,
idea
yes,
because
yes.
you don't have to remove this thing.
Yes.
So because it's not a toric lens, I don't have to dial. It opened in the bag only perfectly. So you can see the Perkins images, they are in the center.
So what would you like to add extra about a Synergy lens? Where it stands in your armamentarium
Uh,
against the other
if
tribes.
somebody has more demanding near vision and not a professional driver, I think all those patients, except near vision, if somebody wants more near vision, EDOF lenses are not good. Yes, no. And very happy to implant this lens in front of the person who said my first IOL, Dr. Maipal Sachdev is here. Yeah. No, the thing is, it happened, so he was doing IOL and suddenly he removed the cortex and said, you put the IOL. Then I said, sir, I have not put the IOL so far. Then you put it, I'll give you a job. Then I implanted the lens. Then he said that today you go and collect all the articles of cyclosporin in corneal endothelial graft rejection. So 2 days I collected all the literature and gave it to him for that IOL. I'm happy.
So I think Dr. Maipal Sachdev sir, this is his
So
way
I'm
of
not
teaching us.
assistant.
This is his way of teaching IOLs.
I was assisting.
He does the whole cataract surgery, then he tells the
Thank you.
JR who's assisting. And I also happen to be one of the JRs that do you want to put IOLs? So, you know, this is how we do our first IOLs, at least during our times in RP center. With Dr. Maipal doing the whole cataract and then making us do the IOL.
Thank you so much, sir. Before we move on to the next case, just a small announcement for all the postgraduates in the hall. From 10:30 onwards, we'll be starting the Sushruta Junior edition of iFest. It will be in the hall B, which is just underneath this hall. We'll be starting with VR surgery basics as the first session from 10:30 onwards. Moving on to the next case, we have a 65-year-old female patient who will be undergoing a right eye cataract surgery. The vision is 636 unaided, and it's a posterior polar cataract. The IOL which will be implanted will be a plus 22.5 diopters Vivity IOL. Over to you, Krishna Prasad, sir.
Am I audible? Hello?
Yes, you're audible.
Okay, so welcome back all the people at the iFest hall as well as the moderators. I'm going to start a case. This is supposed to be a posterior polar cataract because we have not been very sure what it's going to turn out to. So many a times, as most surgeons would actually agree with me, sometimes it turns out to be a hoax, but nevertheless, it's always better to consider every doubtful case as a posterior polar cataract and not to take the risk, because whenever we take too many precautions, it turns out to be a hoax.
Would you routinely do an ASOCT before you take up these polar cataracts for surgery?
Okay, here we have done it actually. There is no obvious defect that we can see in the posterior capsule. There is no any kind of a disturbance right behind it. So I think my premonition goes that probably it will turn out to be a hoax. But nevertheless, for demonstration as well as for the patient safety, we are going to consider this as a posterior polar cataract and go ahead. So I'm going to start my routine surgery. I'm normally it's a right eye, so I'm a right-handed surgeon. So it's the temporal entry. I make my side port around 70 degrees away on the left-hand side and diametrically opposite the other side port. I'm using poor man's viscoelastic HPMC to fill the AC, because that is what I normally do my normal Rexis with, unless it is a case of an intumescent cataract as I showed you previously. Light Nodima? So can we change to okay, light node Thyrima? So getting a Rexis in a posterior polar cataract cannot be viscoelastic cannot be overemphasized, because there are very high chances that you will lose the integrity of the posterior capsule and you may have to end up putting a 3-piece lens in the sulcus, which with an optic capture. So Rexis becomes mandatory in such situation. So at the same time, people also advocate what is called an oval Rexis, light Nodima. In case you are trying to take the nucleus out of the.
So KP, you again have an intraopacity microscope. You can probably see whether the pieces
Exactly.
are right on the table itself.
Yeah. That's a very excellent suggestion, Dr. Namrata. And Dr. Namrata has been one of the pioneers in using the IOCT. She and Dr. Tityal have really revolutionized the use of IOCT in anterior segment surgeries. Because
That's important.
so here the point to consider, I'm not doing a typical hydrodissection which runs through the central part of the posterior. I'm just doing a very limited, you can still call it a limited, very guarded hydrodissection just to separate the anterior capsule from the rest of the lens. Okay, and
So this hydrodissection wave will go behind, but since your ASOCT says it's normal, it's okay. But if the ASOCT were to show any outpouching, then I think no limited hydrodissection is also safe.
no, no, actually it didn't go through. I didn't really push anything hard there. So now, no, she's giving me a dialer to rotate the nucleus by force of habit. My usual scrubbed assistant Ganga. So
KP, if you really want to separate the capsule from the underlying structures,
Hmm.
just use a spatula, no? Sacral
yeah, you can actually use that.
Why
High-risk
use
deposit.
fluid? Yeah.
Yeah, you can always use that. That is again a suggestion I would definitely take. So now you can just use this and separate these. Yes, sir. So now I'm going to. So how do we do this? There are many ways to again skin a cat, and at the same time, we go by what actually happens on the table. Many a times our plan. Light node ma. Isko cornea man. So I'm going to make a trench and crack it into two, and without any rotation. Chopper normal chopper. So I'm doing a vertical chop. It's also in a harder cataract. The central core also. Taking a precaution not to rotate the nucleus. So without
Very nicely demonstrated.
ಮುಗಿತಮ್ಮ ಅಷ್ಟೇ ಮುಗ್ದೆ ಹೋದ್ So this is where the oval rexis comes into help. We can also actually do a trench horizontally. I'm trying to separate, lift the nucleus out of the bag. A softer cataract would be much easier. So I'm just resisting my temptation to rotate it. So I use my epinucleus mode to lift this plaque up.
Very nice. But of late, what we do is whenever we see on ASOCT an intact PC, then we go ahead and do a viscoid dissection at this point of time, if in these kind of situations, because clearly these cases, there will not be a PC blowout unless you have done something, some mistake somewhere.
I think another important take-home message here is, there's a little bit of iris prolapse, but instead of trying to deposit it, and then again it will prolapse out and the process becomes very frequent. Try to finish off the surgery in the same sitting.
Yes.
So now I have to do a bit of struggle because now normally we don't take out the the probe directly like that. So I am using my left hand and using the right side both, which is little of a circus.
Very nice. So
Always
the-
for beginners, reposit the iris from inside, not push it from outside.
And not go in through the same port, go through a different side port and then reposit it. That's one important tip. And the other thing which he clearly showed is don't allow the anterior chamber to shallow. That's why he did the gymnastics of injecting viscoelastic through a remoter side port and then got his phaco probe out.
So somehow I have a feeling that this PC will be intact. So I am actually loading my lens. This is an Alcon VVT on a Clarion platform. So this is a classical EDOF lens. You can actually see a central small bulge there.
Yes.
Okay, there's a small bulge. So these there are different types of mechanisms, but this actually works on the central humps. There's a small hump. There's a change of the power from the periphery to the center. I'm just loading it on a D cartridge. Keep it ready. And now I'm going to go with my IA. So I always start with my irrigation on the right hand side. So this PPC has been so far very relenting and kind to us. Let us see what happens to the capsule. Sometimes even though the capsule may look actually okay, it will be sometimes thin and it can rip off any time if you shallow the AC. So I'm changing hands. It's an important thing here. The ambidextrity comes. I'm not a very ambidextrous person, so then change hands. Because sometimes if there is an upthrust, if the patient is squeezing or if there's a possibility of a scleral collapse, if the forward movement of the capsule is very forceful, it can actually rip off the central weak area and cause PC dehiscence, even with so-called and apparently a intact PC in the beginning. So be careful about this possibility. So lucky for me, as Dr. Chitra has prophesied that we are not going to not have a blowout. Oh. So this is the VVT lens going in. I always do a hydro implantation in most of these cases. And if you see that, well, I was trying to actually lift the nucleus out, I have actually damaged the capsule here. It was a round rhexis. Now you can see there is a runoff here. But nevertheless, it's in the bag. And as Dr. Arup said, this is a floppy iris also. So I'm completing this case. I'm really excited and looking forward to see my teacher operating on the other side, on the 2D side in OT1. Dr. Mahipal Sachdev, as Dr. Namrata alluded, has been my mentor too. And I have personally learned cataract surgery from him. And he used to complete the surgery and we would put the IOL. And we would all actually celebrate, all the postgraduates with him.
So, yeah, and
So-
that is his style. Do the phaco and get
fact-
IOL done by your residents.
I have hosted a party in my room in RPC 1 hostel to Dr. Bahipal and Dr. Titial. That is the kind of humility they have as teachers. And even today, I remember with earnest gratitude for all that we have done. And we can never repay back that kind of teaching that we received at RP Center. And all that we are today is only because of teachers like Dr. Mahipal. So thank you so much. And
Wonderful
Lucky charm.
surgical
Lucky
demonstration.
charm, Dr. Chitra, PC is intact.
Hello, KP, nicely demonstrated.
This
I don't know
Viviti,
if
one-
we can. Yeah.
Viviti, about Viviti, one last question, Dr. KP.
Yeah.
Would you routinely think of doing a micro monovision for the other eye to these patients, even though you may not promise some extra near vision?
Okay, I'll just take this question and quickly move on. See, most people, even if you put a monofocal, a normal monofocal, because of pseudo accommodation, many people are actually happy. But nevertheless, by actually using the latest technology in patients, I would actually want to put a panoptics in every case possible wherever it is applicable. But wherever it is not applicable, because of eye reasons or because of whatever that it can have a late problems that we envisage, VVT is the next best option. It is short of the kind of spectacle independence that trifocals can give, but EDOF lenses is somewhere in between. It is definitely better than a monofocal with monovision. So patients, even if you're emmetrope on both sides, they still have a very useful intermediate vision. If you're very keen on reading small print, then maybe a micro monovision actually would help. So you need to customize in each case. And even where we have done, even without micro monovision, the patients are very happy. So some of our experience with EDOF has been very satisfying, especially in patients where we can't put a trifocal. So thank you so much. I think we'll shift to OT1.
Thank
ಭಾಳ
you.
ಚಲೋ ಆತಮ್ಮ. But
Thank you, sir. So the next case we have is a right eye cataract surgery in a 72-year-old female patient. The vision is 6/18 and the grade of cataract is nuclear sclerosis 3 with cortical cataract. The IOL power is plus 24.50 diopters and the IOL to be implanted is PanOptix from Alcon. The patient has also undergone a LenSex first. So I'll just show the LenSex video and then we'll move on to the surgery.
इसको देख लो जरा कोएक्सियल वगैरह जो है अभी क्या है ये हैं? दोनों है ना ठीक है एंड इफ आई वांट ओनली कोएक्सियल या प्लीज okay where you increase the mag okay yeah हाँ ठीक है ओके इनको बोलो लाइट में देखेंगे
सीधा लाइट नोड रही हमारा अकड़े कट ನೋಡಬಾರದು सीधा लाइट ನೋಡ್ತಾರೆ
ಲೈಟ್ ನೋಡ್ರಿ
ಹಾ ಹಂಗೆ ಬಂದ ಸೈಡ್ ನೋಡ್ತಾರೆ ಅಕಡೆ ಕಟ್ ನೋಡಬೇಡ ಯಸ್ ಕರೆಕ್ಟ್ ಇದೆ ಹಂಗೆ
okay इसको ना थोड़ा सा टेप को दोबारा प्रेस कर लो प्रेस इट
We move on to the surgery now. Over
Yeah.
to you, Miss Dr. Mahipal Sachdev, sir.
yeah hi am I audible
Yes.
okay have they told you about the LenSex
They did show the process happening, but yes,
Okay.
I would want to see whether your Rexis comes out free floating.
okay that's fine so basically we have done a 5.2 Rexis and I'm sitting temporally there are 6 quadrants इनको बोलना हिलना नहीं है there are 6 quadrants that are being made I start with the side port Phenocan I normally put Phenocan but they don't use it here so I'm just using Epitrate but Phenocan has the additional advantage of having the HPMC. Phenocan has the additional advantage of having the xylocaine in it. So that's intracameral. So you can see this capsulotomy has floated up. Can you see this?
Yes, yes.
Okay, so I'll now give me a forceps and this thing blade entry. Normally when I have a tight globe, I'll prefer to do the entry then. So just a slight limbal. So normally, most of us, because of the arcus and all, we are not doing the incision to a large extent. So that has not been done here. So give me a needle. So now I'll show you the free-floating rexes. With the soft fit, that is the contact lens, which is you didn't bend it? Bend it. With the contact lens that has come in, the incidence of posterior corneal folds have gone down. Okay, so you don't get skip areas now anymore. So whether it's the liquid optic interface or it's the soft fit, LensX soft fit, you can see that's a free floating rexes, right?
Yes.
I'll
You
just.
don't get those SCHs also nowadays.
Yeah, now you don't get the SCH. So you see, I'm going below just a little bit of a hydrodissection that is required. Actually, pneumodissection has already happened.
Yes.
So you can see I'll just see that the nucleus is rotating. You can see it's a small eye. Actually, the lens power is about 24.5 or 25. Okay, so you can see that the nucleus is mobile. Can you see that?
Yes.
So this is Viscoat that is being used. It's a Duovis. So I just inject Viscoat and some methyl cellulose to have the corneal endothelium. Yeah, chopper. Give me the phaco piece. Huh? So this is the chopper that I showed.
Now,
This is the chopper that I use. So you can see the chopper. It's a sharp cutting aside the inside as also the bottom, right? ये मुझे देना है. So yeah, you were saying something?
no, normally in your soft cataract, would you just like to create the grooves and not do the softening?
I have not done softening.
You have not done it here.
So it's
Yes.
not actually a soft cataract. They did write soft, but I think it's a grade
Moderate
three
cataract, yes.
cataract.
Yes.
And it's I don't know her age. Age क्या है इनका? What is their age of the patient? She is 61, so I don't expect the cataract to be that soft. So
Yes.
anyway, 72. Okay, gone up by a decade. Okay, so basically, so cornea wet kar dena. So what we have done is we have made 6 quadrants, and you can see that I'm just going in there. So this is a balance tip with you can see that the crack is pretty good. थोड़ा ना इसका वो बढ़ा दो फ्लूइड का कितना रखा है? No, not flow rate. I mean the irrigation pressure. Bottle height जो है ना, I don't know what it is now. Okay, that's fine. IOP I've just increased because I was getting a little shallowing.
And it's
Because
a small eye also, so makes sense.
Yeah. So you can see again in this quadrant, we are able to hold it. Just crack. Give me the quadrant now. I'm shifting on to the quadrant mode. Done? Yes. Okay. So you can see there is very little power that has been used. And this has the nozzle. So that's one piece gone. So I felt it was a little harder, so I didn't do 4, I did 6 quadrants. And you can see that you can be right in the central area. There isn't much of a repulsion, and you can see that the nuclear fragments get attracted very well. Epi kar do. Last piece, I normally tend to reduce my settings, and you can see that's the amount of energy that you use is much less. I don't know what is this thing. Okay, so you can see that it's a very less energy. Give me the coaxial, the bimanual. sorry, not the bimanual, coaxial. I normally, again, this will always be a discussion point, but I am used to the coaxial and, so this is,
Going back to your case, I expected it to be a soft cataract, but this is a moderate cataract.
no,
Do you have use some softening in this kind of cataract?
no, I don't need to because the quadrants are fine. So,
Fine.
but the machine was excellent. You can use softening also. That's what.
Yes.
Give me a forceps, please. So normally I inject viscoelastic in a in this IA, and I'll just go and start from subincisional.
Had
Okay.
it been a non
See, you can see
LRCS,
that this is a subincisional one. So you can see it comes out pretty well when there is a lot of visco there. And then once you have that cleavage plane, you just continue along with it. And that's important that you go along with it rather than have a new place to start with, because it becomes much easier with one side detached for the cortex. Okay. बेटे आप ना लेंस लोड कर लीजिएगा. थोड़ा विस्को देना मुझे. Yeah, you were saying something, Dr. Chitra.
if it were theoretically a soft cataract and you did not have the LRCS mode, then what would be your approach? Would you think of doing a hydro delamination in those eyes, or
Yeah,
you
yeah, so
feel there's
you can
no sense?
actually, you have to, it's a very soft cataract. It has to be just a,
Flip.
yeah, it has to be just a chip and flip, or you can do a spring technique. So that is what we do. So you want to do, you can have a saucerization if you are, yeah, I'm getting fogging. Okay, so basically what we do in that particular case is that I will do a hydrodissection and a delineation. And because I do a hydrodissection and a delineation, इसपे फूक मारो जरा. So because you do a hydrodissection and a delineation, what you get is that you can get the whole thing come out. Yeah,
Yes.
thanks. So that is, you can come to the supracapsular area.
Yes.
And you can get a very good emulsion because there is no power that you are using. So you can do it slightly cornea wet kar do. You can do it slightly cornea wet karo. You can do it on the supracapsular area. Okay. I'm actually a fan person. I always have a fan in my OT because I tend to fog. So I'm not able to see much. Anyway, see. Okay. So anyway, you can see that I've been able to work my way with the entire cortex. There's a little cortex left here.
You've shown cortex removal very explicitly with your coaxial, but I am a ardent believer of bimanual. I know it comes so easily with a bimanual.
So I'll just put the IOL first and then remove this little part later. So basically you can see the speed with which we can remove, and we don't have to really switch our hands. So this is a Panoptix. You can see this is a yellow lens. It blocks both the UV and the blue, this thing. It has the central 4.25, and this is a push type. So you can see I'm just pushing it. I prefer the screw type. I have injured the posterior capsule of a speaker of a assembly. So basically you can see this is central 4.25 is the lens. नहीं मुझे since की दो. Has the various zones. It is actually a 4-zone, but it has been put into 3, and it has about more than 80% light transmission. 3.25 for near and 2.18 for intermediate, and normally patient satisfaction is very high. And what else?
The patient satisfaction is also high because it has a one large central optic zone.
Yeah,
So it
that's,
doesn't matter if your angle alphas are little more also, you can put a multifocal in these, right?
yeah, so basically the other thing from the here is that the light transmission is pretty good, and
80.
basically for if you have long arms and all, so this is a true intermediate lens.
Yes,
Uh,
60
60 yeah.
centimeters.
So anyway, this is the, I'm just washing the viscoelastic. You can see that they have apodization that they have for the lens, and the dysphotopsias are much less. Cornea wet color. So this is pretty much the surgery. Any questions you have, I'll just hydrate. You can see that.
Just one last, one
yeah.
question. See, Panoptix is a great lens and you can put it bilaterally and they do well.
Yeah.
But in case you feel it's a fussy patient, would you consider doing a mix and match by giving Vivity in a dominant eye and a Panoptix in a non-dominant eye?
I haven't done that because both these lenses have, I really don't, I'm not a great fan of EDOF. I started with EDOF with the Symphony came in, but I prefer enhanced monofocal to an EDOF. And regarding mix and match, I would do a Vivity with a Vivity and a slight manipulator with a slight monovision.
Yes, yes.
Y ka single side. So you can see there is a small, this is what happens with the phaco. You can see, can you see this? There was a small piece that that was at the,
Yes.
can you see that? It's
Yes,
still
yes.
stuck. I'll just,
It
so
was-
basically you need to, these can cause inflammation.
Inflammation.
Once you stop the steroids,
Yes.
they just go and lodge in the, near the trabecular meshwork, and they cause inflammation. So you should, specifically in the horizontal movement, they push it towards the incision. So you have to look at the incision site to see, and this is pretty much the end of the surgery. So I don't, as I said, I will prefer to do, Sida dekhiye, ask her to look straight. I'll prefer to, no, look in the light. I prefer to do a mini monovision for
Yes.
an EDOF rather than doing a
Yes, yes.
Panoptix with a Vivity.
Yes,
I haven't
that's-
done that.
Yes, that's also a very favorable approach.
Yeah.
I just
the-
wanted to know whether this could also be
So
considered.
you can see that this is a tight globe.
Yes.
The Vigamox dalte? Huh? So basically you can see that what is said is that at the end of the procedure, if it's a soft globe, then there can be ingress of the bacteria, etc. from the site. So it's always better to have a tight globe rather than a loose globe, okay? And
Yes.
this is moxifloxacillin, that is our standard of care today, 0.1 that we put in the patient. Thank you. So
Very,
that's-
very well done surgery and all the explanations very well covered.
Thank you.
Congratulations, Ram.
Thank you. Thank you. Actually, the microscope was also nice. This is a Luxor microscope that we had, which is giving us 6 times or something greater coaxial view, and the depth perception is fantastic. So this is what I used. So it was a Luxor, a Centurion, and a Lensex and Panoptix. Yeah.
Alcon suite.
Yeah. Okay. Thank you.
Thank you.
Thank you.
Thank you so much, sir. We now move on to our next case, which is a right eye cataract surgery in a 62-year-old male patient. The visual acuity is counting fingers at half meters. It is a nucleosclerosis grade 2 with posterior subcapsular cataract with a relatively lesser pupillary dilatation. The fundus is normal, and the IOL which will be implanted is a plus 20.5 diopter Clarion IOL. I request Dr. Arup Chakrabarti, sir, to be the discussant for this case. Over to you, the operating surgeon, Dr. Shilpa Maled, ma'am.
Thank you. So I just wanted to show how iris hooks will be of very great help while operating onto a non-dilating or a small dilating pupil or a mid-dilated pupil. So I made 2 side port incisions the way I need it always. Another, there are 5 iris hooks. Few people prefer to put 4, few people prefer to put 4 iris hooks, having an adequate dilatation. So KP sir is here. KP sir would, oh, okay, sir, both Dr. Partha sir and KP sir would say for this you need iris hooks, sir, because it works wonderfully in their hands. But I don't want to take any chances in live surgery, so I'll be putting iris hooks.
Do you have phenocaine? Have you tried intracameral phenocaine in this? Because I'm sure
have,
it'll,
yes, ma'am, I
it will
have.
dilate if you.
Bisco. I had, iris hooks ತಗೊಳ್ಳಿ. ಕೊಡು, ನನ್ ಕಡೆ ಇದೆ, ಕೊಡು.
Shilpa, I'm sure with your expertise, you'll do it even without the iris hooks.
So actually, this was for the demonstration for the sake of beginners who really are little hesitant to use hooks and rings. That is the reason. As you said, ma'am, I really don't use. I'm little lazy person. So yes, sir. My pleasure.
So Shilpa, I think things have gone on extremely well. But what I would have done a little differently
Yes,
is
sir.
when you make those paracentesis incisions,
Yes, sir.
inject OVD into the anterior chamber or inflate, make the eye little harder. Because you don't need to apply so much of pressure when you go into the anterior chamber. Because sometimes the momentum, might carry the blade forward and you may end up damaging the iris or sometimes the underlying capsule.
Yes, sir. Very well said, sir. But what I used to have the thing was then the iris would have been pushed behind so badly, tucking the iris hooks in the iris, feeding the iris would have been difficult at times.
No,
for
no,
me.
no, I'm talking about when you are making the paracentesis incisions. All right, at that stage, you require little hardened eye. But you can always remove the OVD when when you're engaging the eye hooks to the pupillary margin. I'm just telling that when you enter the anterior chamber, it's always better not to have a very soft eye.
So once I just start tucking the iris hooks, these are not tightly secured, because I would secure them once I know how much dilatation I need to without damaging the pupillary margin.
I think this is the correct technique of engaging the pupillary margin. So, she has not retracted the hook. She has just engaged the hook. And then once all the four hooks are engaged, then you decide, what is the kind of traction you require on the silicone sleeve there, silicone ring, and what are the pupillary size you expect.
Absolutely, Arup, what you said is a very correct, but I think I would like to ask Shilpa whether she would like to, how many of BHEX rings she uses vis-a-vis the hooks?
Sir, I'm surgeon of. So I need to be very careful with my words, but with due respect to all the rings and the ring owners, I would say iris hooks are very simple to use. It has very shortest learning curve.
Correct.
And see, for a beginner, no, investing in so much. And second thing is there is not much of control of the rings when they are inside the eye, because they don't have a connection outside. Here I have a good control when I'm using iris hooks. I have used those rings. I wouldn't mind them using, but then I just want to send that you should not be unhappy or what you say, hesitant, because you can't use a ring. You are not operating onto a small pupil.
Correct.
So the message should be use either hook or ring, but it should be done
Correct.
in a proper way.
Very good, Shilpa. And Arup, I think we are seeing Shilpa very atraumatically holding that side port. She's not grasped the side port. She's just put in the two lips of the forceps on the side port. So that's very, very atraumatic. Very nice technique.
Because initial light देखते रहिए. Initial phases for a beginner who want to shift to topical, it is a good idea to hold at the side port and not the conjunctiva, because the patient would be really, it will be painful for them if you're holding conjunctiva.
Quite true. So this is a very nice method and to do it. So was a this is a PPC which you have done a hydro delamination.
No, sir, this is NS3 and a PSC case. Though it looked like, but it is not PPC.
See, another thing I would consider doing here is the two para incisional hooks. You can just relax them a little bit, let the iris fall down, so that you have a deep anterior chamber when you enter with the phaco handpiece into the anterior chamber. Otherwise, you may have like what you're experiencing right now, some of the chafing happen. I mean, of course, it is not very traumatic as such, what the kind of chafing you had, but that could have been avoided if you had relaxed the iris hooks and let the iris fall back posteriorly.
So what I do is, because of iris hooks, there will be some kind of tenting of the iris. So I don't enter with irrigation on inside the chamber. So that helps me. And my pupillary dilatation doesn't come down. If I relax those hooks, the pupillary dilatation might come down, is my worry.
Once the Rex's hydro is done, you can even remove the iris hooks. Usually people will be dilated. So
what about the pupillary margin becoming little bit of floppiness the iris will get after?
no, it will be well dilated. You can continue without the iris hooks from this step onwards.
But if it was a case of real small pupil and it could IFIS candidate, I think, it is always a good idea to have the iris hooks in situ. You can relax them, you don't have to be, tenting up the iris, pupillary margin towards the cornea. But in case you have repeated iris prolapse and it's an IFIS candidate, then it definitely helps your case.
These hard cataracts, always getting one piece out makes the surgery a lot more easier. Even if the posterior plate is not separated, you can, at some point of time, keep eating up the peripheral pieces, and then you have the central cord wherein you can inject viscoelastic and push up that piece and carousel it out. So she's showing that very well.
Can you tell us a bit about the phaco parameter settings?
My
I'll
vacuum.
tell-
Because we don't see the video overlay here.
I will tell you, she set the IOP at 48 and the vacuum going up to around
Yeah, and
630.
it is visible now. You
Yeah.
can see it here.
Aspiration flow 38.
And regarding, the strategies of the number of hooks to be used, some people actually believe in using 5 hooks. So that way, the pupil gets symmetrically stretched, and post-operative cosmos is a little better. And here, for example, you have 2 iris hooks quite away from the main incision. So that stretches out the iris and pupillary margin under the phaco handpiece. So if you can have, the 2 iris hooks just adjacent to the incisions, in that case, you will have the iris in the pulled out of harm's way. So whenever you enter the anterior chamber, nothing is going to, nothing, you're not going to encounter the iris. So pentagon approach is another approach which helps in many situations.
Also,
And
this
the
having.
diagonal, diagonal. This is actually not a diagonal, this thing. Some surgeons would make a diagonal, you make a paracentesis just behind the clear corneal incision.
Yes.
And then, change the shape of the quadrilateral.
Also, the iris is also tightly held between the 2 hooks. So that, you prevent any iris chafing happening, because it remains taut between the 2 iris hooks if there is a subincisional iris hook.
I think we really need to note the chamber stability, which is excellent. And there's hardly a surge after surge.
There are a lot of PC cells. I would clean them.
The better your microscope, the more the PC cells you'll detect.
And you don't feel leaving them like that. Yes, this is what I can clean up now. Let's go. Lens, please.
Very well done surgery, Dr. Shilpa.
Shilpa, you
I
do
was-
so effortlessly. You are also watching with your goggles 3D. It looks as though you're not doing, somebody else is doing on the middle screen and you are watching with us. But
Yes.
wonderful, effortless.
All thanks to you all, so that you are discussing, I am doing the surgery. Otherwise, talking and operating is really difficult for me. So I am using Clarion Autonomy. Let me show the lens. It's a preloaded lens. It has a carbon dioxide canister in that. You can see the lens. I have filled in the viscoelastic substance. Little more I would like to fill. Now just have to press onto this so that the carbon dioxide is released and the lens starts moving. The more I press, the more the lens gets released. So at this stage, I stop. I really don't let it go to the tip of the or bevel of the cartridge. Forceps the body. And once I start injecting, I press, I let the lens go inside because it opens up very quickly and in an unpredicted way sometimes. So unfortunately, it got unfolded in the anterior chamber. It's a wonderful platform. This Clarion lens, now all the Alcon lenses are coming on to Alcon platform. The thing here is it is very few vacuoles or the lens vacuoles what we used to see with IQ lenses. We are not seeing here with the Clarion platform.
How frequently we have this, the leading aptic got sort of, distorted and reversed? Is it a very common occurrence? Or?
It doesn't get flipped, sir, but definitely it doesn't go like the way IQ or the normal Clarion goes into the bag. This doesn't go in the bag. I have to put it or set it in the bag. That's the only worry. I guess it needs a little bit of more learning curve.
The other thing, Arup, in the Clarion with the this injector system, if it goes right with the haptic pointing inside, then it is best that it is injected under viscoelastic and not under irrigation. Because
Exactly.
then under irrigation, you don't have control of the anterior chamber and it might really at times damage the posterior capsule as well.
So would you prefer to use the injector system or just load it yourself? Given a choice.
Well, the choice is there, then of course the injector system is definitely the better way to go. But when you load it yourself, then you are sure that the haptic is folded over the optic, both the trailing as well as the leading.
So that definitely is the advantage that you're looking at,
Yes,
isn't it?
that is an advantage that you're looking at.
For me, it is easier to inject under hydroimplantation. So
Yes, yes.
I also personally don't prefer the preloaded one, especially in cases where you're putting hooks and everything because your maneuverability is little more difficult. I would have preferred, but
So Shilpa, we also see the beautiful rhexis overlap on your optic, which is excellent, I think. Absolutely a 0.5 to 0.75 millimeter overlap. Excellent.
So Shilpa, another question for you.
yes, sir.
Like, I mean, of course, a lovely surgery, we really enjoyed. How does, is there a difference in the feel when you use manual loading technique of Clarion and the IQ?
Sir, simplicity, I said, I don't like too many gadgety and
No, no,
hi-fi things.
IQ versus Clarion, when you load it
IQ
yourself.
versus Clarion, yes, sir. Clarion is more better because it is a little sleeker, thinner lens. It slides very easily. We don't have stacking up and folding up or getting the shooting of the lens with Clarion is lesser compared to IQ.
Thank you, ma'am. Move on to the what you want, ma'am.
Okay. Yeah.
Thank you, ma'am.
Thank you. Thank you, sir.
Excellent
Thank you
surgery.
so much.
Shail Vasavada is ready with his surgery. Now he will be demonstrating an implantation of a toric IOL. And he'll be using the Centurion machine on the Raxarevalia microscope. And this is a situation where he's going to use the digital marking system of Varion. Over to Dr. Shail Vasavada,
Very
a
good
man to
morning.
look up to.
Morning. Thank you, KP sir. After making the first side port, I first inject intracameral 1% preservative-free xylocaine, and then the first injection that goes inside the eye is a dispersive viscoelastic. So this is Viscoat in this case. So this will coat the endothelium, and below this dispersive viscoelastic, I'm now going to go inside and inject a sodium hyaluronate cohesive viscoelastic. Provisc is in this case. So that will help create space, and that will paste the endothelium up onto, paste the viscoat back up on onto the endothelium. After the chamber is formed, that's the time when I make the second side port and the main incision. So having made the first side port, now because I like to do bimanual, I make two side port incisions. And typically my size of incision is generally a 2.2 millimeters. That's my preference for most situations. It's important that the incision is limbal, and you want to make a single plane incision as if you want to go and hit the endothelium. You're never going to be doing that, but that will make sure that the incision is of a reasonably decent length. Now, there was a discussion in the first few surgeries regarding from where to do the capsulorhexis with the cystitome. I think except for a very mature cataract, I would suggest at least for the beginners to use the main incision, because that allows a lot of maneuverability. So you have a lot of scope to, as you can see, move my cystitome across the incision and change the angles. So I'm using the digital overlay on my microscope, which I've set at a rhexis size of 5.1 millimeters, which generally I would normally make a rhexis slightly smaller or inside that circle. So depending on how bold or how timid a surgeon you are, you can choose your rhexis size accordingly. So I've chosen a rhexis size of 5.1, and I'm generally going to be doing inside that circle. So I'll end up somewhere between 4.8, 4.9 or so. I think amongst all the features of the digital marking and amongst all the calculations and other things that are done with the swept source biometry here, in this case, the Argos, this is the feature I think I love the most, because it allows you to do a very nice centered capsulorhexis and a circular capsulorhexis, making sure that your overlap over the IOL is perfect. So this is a modified hydrodissection cannula, actually originally modified by Dr. Akaoshi from Japan. So here, instead of lifting the capsule up, you just rest it on the lens and you can see a nice wave. So if I normally see a nice wave, I typically don't attempt rotation. I just inject Viscoat before I start the phacoemulsification again. Phacoprobe, and the chopper. So this is a grade 2 cataract, and it has a very small central nucleus. So quite often in these, very small central nuclei, chopping becomes quite difficult. So I'll first attempt to do a chop, and if that doesn't work out, then probably I'll shift and fall back to a 4-quadrant technique. It's important that you squirt out some fluid outside so that bubbles don't come in once you go inside, and only once you're inside, turn on your foot pedal. Yeah. So I'm aspirating the viscoelastic. Now I'll move on to the sculpt mode. Yeah, with an intraocular pressure of 20 and an oscil of 30, which is torsional. I prefer to use torsional at all situations. Chop. So since it's a soft cataract, I've kept my power at 25 and the vacuum as modest 350. So having created a crack, it's much easier to rotate and more stress less to the zonules. So I'm going in foot position 3, occlude, then come up in foot position 2, initiate a crack, and then do lateral separation and complete the crack. So this is typically what is described as chop in C2 and lateral separation. Occlude, foot position 2, initiate a crack, and then try and complete it. We can increase the power to 35. This typically sometimes does occur. You end up chopping a few and then it doesn't typically divide completely. I'll move to quadrant mode now, where my nozzle is now 30. I've increased the intraocular pressure to 30 now, because here we'll be removing the fragment. So the output is going to be more. I've kept a flow rate of only 20 cc per minute. That will make sure things happen slowly, but that will also make sure things happen under control. I'm trying to keep my phaco probe as central and as stable as possible, and whatever movements that are being done, I try to do it with the left hand. What that does is it allows the fluidics to remain centrally placed. So with the balance tip, we practically need to use very little power. So at least a 30% drop in the nozzle that you would normally have used with the normal tip, Kelman tip, you need only you need at least 30% less. I like to inject Viscode before I come out always. The reason for that is that even if there is any nick or any extension or something that has gone off in the capsule, this acts as a security barrier. My preference is to always use bimanual irrigation aspiration. That allows me good ergonomic access all around. And generally, I'm operating on complete coaxial. So that's my preference with any microscope. These are not my bimanuals, these ones. Thank you.
One quick comment as Shail waits for his instruments. You look at the draping of the eye lashes and the eyelid margin. You know, the entire conjunctival sac has been sequestrated, you know, from the sources of contamination.
Very important point, sir. Very important point. So coming to the IA, now I've kept my intraocular pressure as 30. Because once again here the output is a little more. My vacuum is a modest 350 and I've kept my flow rate at 20. So these are typically my standard settings irrespective of the density or the type of pupil. And I think this kind of lower parameters help you safeguard against all situations. So even if it's a smallish pupil, again, even if it's an IFIS case, you'll hardly ever see the iris fluctuating or the pupil coming down or the iris coming to the side port because your parameters are already quite low. It's actually fluid turbulence inside the eye which leads to iris misbehavior and the iris coming out to different ports. So I think going lower can generally never go wrong. The only thing that can go wrong is the time taken during surgery. And therefore, I'm I'm lucky I'm operating in the later half so that all the quick surgeries have already been completed before me.
What time? 11, that is the afternoon, no?
So this is something that I've learned from Viraj, positioning, occluding, then swiping, and only then I raise my vacuum and when I bring it to the center. So if you keep looking at the parameters, when I'm occluding, although my preset is 350, it will be around 50 to 100. Then I swipe, then I keep pressing my foot pedal as I keep bringing the cortex in the center, and then I go full throttle. And immediately once the full throttle is about to get over, raise your foot pedal so that there is less chances of surge.
Another important point to note, you
polish
have not opened the speculum too wide.
Yeah.
Now, sometimes, the surge gets aggravated when you're working on such low parameters and you get a PC then. That is
Correct.
another important
Yeah.
message.
And I think the IOP number is not important. I think what I'm trying to drive is that whatever you're using, you can always go a step lower and see how low you're comfortable with ProVisc. So there wasn't much on the posterior capsule. So now once again, I'm injecting cohesive viscoelastic to fill up the capsular bag and the anterior chamber. I always like to inject the IOLs under cohesive because it gives me a lot of ease of implanting the IOL inside. I can load the IOL, no problem. You've loaded it? No, okay, yeah, just pass it on. So just filling a little bit of ProVisc in the cartridge, cohesive. Yeah. I'll need the cartridge in my left hand. So I think the thing that has changed with the Clarion platform, of course, the optical material has changed. From a surgeon's point of view, because there is can you just wash the IOL with some saline? What has changed is that because there is a little bit of hydrophilicity or the water content has increased in the IOL, manipulation has become a little more easier. So the stiffness that used to occur while injecting or while loading is much less than what it used to be with the Acrysoft platform. Can I have my own forceps? This one. Yeah, this one. Sorry. So just close the forceps tip. I always like to use a shooter kind of injector. I know there are issues, there can be issues with the shooter injector, but I like to do a wound assisted delivery. So the injector that I like to use with no financial interest is an Esico Royal injector, which is far Lester Hook, the manipulator, yeah, which is sorry, sir. Yeah, which is far more smoother than the conventional Epsilon ones that are there. Because it's being injected under viscoelastic, it gives me a lot of time to manipulate the IOL and place it inside the capsular bag, both the leading and the trailing haptics. And I can also make sure that I'm at least 10-15 degrees off the placement axis so that when I have to remove the viscoelastic and dial it, I can always use clockwise rotation occurring. Yes. So this is the only time during surgery when I increase my parameters. So I'll increase my IOP to 50. I'll increase my vacuum to 500 and the flow rate to 40 cc per minute. The irrigation is now behind the IOL. That will drive the viscoelastic, and because it's cohesive, it usually comes out quite easily as one bolus. So I'm just manipulating the irrigation so that the cohesive comes out, and as you saw, it came out nicely in one bolus. What you see, the frills being, moving around in the anterior chamber is actually viscoat, which is the dispersive viscoelastic. I'll change to polish mode. So it's good that it remains right up to the end of surgery. And now I use my same bimanual irrigation aspiration to rotate the IOL into the desired axis, which in this case is a 5-degree placement axis. I don't need to keep changing instruments. Can you put some saline on the cornea? nor I need to worry whether the instrument is sharp and it will cut the anterior or posterior capsule or anything like that. So the IOL is very much in position. It's a slightly smallish rhexis, but I'll always prefer a slightly smallish rhexis over a slightly larger rhexis in a toric case. And once again, I'll make sure that I hydrate the wounds before I bring it out, because you don't want a toric IOL to rotate. So my irrigation is off now. With my right hand, I'll first hydrate the first side port, then the main port, and only then will I remove the irrigation out of the eye. And I think you can consider doing this as a habit in all cases, so that in cases with posterior polar or torics, it doesn't come as a surprise to you.
This, Shail, it is a very well done surgery, quite immaculate, and, your commentary was also quite,
yes,
informative, it was in line with what we are doing.
Thank you,
So,
sir. And this
wonderful
is
job.
intracameral. And this is intracameral moxifloxacin at the end of surgery. Once again, thank you so much for patient observation. And thank you so much to KP sir, Dr. Srinivas, and the entire MM Joshi team for such meticulous arrangements.
Thank you so much, sir. In the interest of time, by the time we have the next case ready in the OT, we'll call on the chair people for the next session to please.
Wonderful surgery, Shail.
Thank you everyone for your wonderful comments, and it was a very smooth sailing. Dr. Shail actually has a smooth sail and always, and very informative, and one of the most informative surgery that I have seen, where you saw the digital marker being used to implant the IOL, toric IOL. And you can have one talk, and later we'll come back with the surgery by Dr. Partha Bishwas.
Thank you, sir. I would like to call upon the chairman of the next session, Dr. S.V. Koti, sir, the co-chairman, Dr. Shravan Pandit, sir, the convener, Dr. V.S. Sajjanar, sir, and the moderator, Dr. Satyajit Sinha, sir. Sir, if you could please just occupy the chairs at the front. We'll just take up one talk in the middle while the OR is ready with the next case.
Hold on.
I like to call Dr. Anup Chakravarti, a senior consultant, director of Chakravarti Eye Care Center, Trivandrum, president of Kerala Society of Ophthalmic Surgeons in 2021-22, IRS International Council member. He has got a very big biodata. I'm just editing them. He is a passionate teacher and has conducted 215 instruction course as a chief instructor. He was elected as member of the highly prestigious and exclusive International Intraocular Implant Club IIC in 2015. He has been admitted as a fellow of American College of Surgeons, FACS, in 2023. Dr. Anup has edited 3 books: Cataract Surgery in Diseased Eye, Posterior Capsule Rent, then Posterior Segment Complications of Cataract Surgery. Dr. Anup has given more than 1,500 presentations as faculty for workshops and instructions courses in various state zones, international conferences. He has more than 75 publications, international, national, and state conferences. And I present Dr. Anup Chakravarti.
Good morning, friends. My first opening remark in the meetings organized by MM Joshi is it is a very, very fond homecoming for me. And I would like to thank Dr. Satyamurthy and the MM Joshi team for calling me here. Now, toric intraocular lenses have become the standard of care for managing cataracts with pre-existing corneal astigmatism. Before these lenses became available, I used to use limbal relaxing incisions or paired opposite clear corneal incisions. But when these lenses came, and I realized that they have a lot of merits, these lenses do not have the downsides like what you see with the multifocal lenses with the optics. So I immediately switched on to the toric lenses, and I stopped the other ways of managing pre-existing corneal astigmatism. See, the main difference between toric IOL and the monofocal IOL that we are so well versed with is it's not a fill it and forget it kind of case. As far as the toric IOL is concerned, you need to do a lot of background activities around the patient workup, and the post-operative period also has to be sort of more intense because you need to be monitoring how you are performing. So basically, what I'm going to talk to you today is about the guidelines which I follow in my toric IOL patient surgery practice. And this keep evolving depending upon my experience and new experiences and the newer lenses that come up in the market. So it is very important to select the patient properly. You need to know what are the indications and contraindications for a toric IOL in the given case. Then the preoperative workup has to be a very focused one. It is a precision surgery. So your measurements, the biometric parameters that you get have to be spot on. And then you use the appropriate IOL calculator, IOL power calculator. And it does really make a big difference, as I'll tell you later on. And then select a toric lens, which has a good track record of rotational stability. And then, of course, you need to refine your surgical techniques and a few comments on that. So these are some of the contraindications for toric IOL implantation. The last 3 are relative contraindications. And if you are dealing with a stable situation, keratoconus or well-treated epithelial basal membrane disease, or high myopia. I would suggest that in the initial stages, one may not take up these cases, but later on it is okay. And before a toric IOL workup is done, we have known that ocular surface plays a very important role in the measurements, in the precision of the measurements. So you have to look for ocular surface disease. And if it is present, that has to be optimized, surface has to be optimized. And the readings may have to be taken and repeated several times before you decide to go ahead. I use optical biometer, IOL Master 500 still, though it is a low density keratometry, it measures only 6 points. Then I back it up with topography and eye trace. So this basically gives me an idea about whether I'm dealing with a regular astigmatism or irregular astigmatism. And if there is any discordance between, what the numbers thrown up by these devices, if it is more than, let's say, 10 degrees, I would not do a toric lens, toric IOL for that given patient. But if more or less, they give me the same numbers, I'll go ahead with the toric intraocular lens. So in the initial days of toric IOL surgery, there are certain post-operative astigmatic refractive surprises. For example, No, there was undercorrection, overcorrection of against the rule astigmatism and undercorrection with the rule astigmatism, and undercorrection of against the rule astigmatism. So it was actually highlighted by Dr. Doug Koch and his team. He brought us back to the concept of the posterior corneal astigmatism, which was already there. He just emphasized that this is the reason why some of the surprising results are being encountered. And so we really need to measure the posterior corneal astigmatism before we start toric surgery. There have been a lot of publications in the literature, which basically give us the take-home message that presently direct measurement of the posterior corneal surface for toric power calculations is not better than predicting its power with theoretical models or regression formulas. So formulas have evolved, so formulas have taken into account the posterior corneal astigmatism. So we really don't have to invest into a device which measures the posterior corneal astigmatism and then incorporate in the formulas in indicated cases to calculate the toric lens power. So you have got the data, very pristine data. Now, it is also important to choose a toric calculator appropriately. In the early days, I was using the Alpine's calculator, Noel Alpine's calculator, and the Barrett's calculator. These are the generic calculators, and they were way above the company calculators, the commercial calculators, various companies, Alcon or Johnson Johnson, Zeiss had, because those formulas had not taken into account some of the important features. See, there's another thing on alert on axis flip. What would be my target refraction? I go for the lowest preoperative postoperative residual astigmatism. So even if it means flipping the axis to the other side, it doesn't really matter, but it doesn't make any difference. So this has to be a target refraction. Then see the toricity factor of the lens depends upon corneal steepness, flat cornea, thick or a steep cornea or axial length. These are initially people used to talk about conversion factors vary upon these parameters, but now most of the formulas have taken these already into account. So there's no point in talking about those conversion factors. And as I mentioned, the newer formulas have factored in the posterior corneal astigmatism, and the newer formulas also rely on very dependable IOL calculators, which gives us the emmetropic power. So basically, I use the Barrett toric calculator because it takes care of all the requirements. Now, as regards when would I use a toric IOL? What was the minimum cutoff? See, all my cataract patients, basically the information is fed into the Barrett toric calculator. So that is my go-to calculator. I learned it in one of the APSCRS meetings 7-8 years back. And then if the calculator comes up with a toric IOL, then I'll suggest it to the patient that you will benefit by using a toric lens. And then if the patient can afford it, we go ahead. So there is nothing like one diopter, 1.5 diopter for with the rule astigmatism or 0.5 diopter for against the rule. Nothing, because the posterior corneal astigmatism, can take care of a lot of, make these kind of discussions heavier. So use the Barrett toric calculator. And a Barrett toric calculator gives you a lot of features. For example, those of you who are not familiar with it, you can use the predicted PCA if you have not measured the posterior corneal astigmatism, or you can use the measured PCA if you have got instrument to measure it. Then the K calculator, like you have measured the K with various devices. So you can sort of get an average, a median rather, which gives you the particular K, integrated K, and then it makes your calculation that much more accurate. So some of the newer formulas are very promising, that the Kane formula, it has particularly for keratoconus patient, it has shown that it has outperformed the other rivals in the Barrett formula or EVO2 or Holiday 2 in whatever is your predicted refractive error you are looking for, 0.5 diopter or 0.75 diopter or 1 diopter. So that is what. Now, as regards the rotational stability of toric IOL, about 4 or 5 years back, it was just an anecdotal. Different surgeons had their different ideas about which lens rotates and which lens doesn't rotate. Now, David Chang and his team came up with this publication, and where he showed that the Technis toric had a much significant degree of rotation compared to the acris of toric. So, and that particular study also showed us that, there's no point in injecting a CTR routinely for all torical patients. And, there are large amount of rotation can happen in patients who have a longer axial length, lower spherical IL power, or with the rule axis. So these are some of the studies that have been done where, regarding as regards IL stability. Now, this is actually, I would like to talk about, can I take 1 minute or so? The surgical aspects. I always do a manual marking, and that is using the slit lamp marking, and on an undilated pupil. So you have to make sure that slit lamp that you use has a length not less than 10 millimeters. A new slit lamp I purchased from Muller-Wedel, from Hackstead rather, it had just a short length, and it was not measuring the full limbal diameter. And just because you're using slit lamp marking doesn't mean that you are safe all the time, because most of the time you require a patient who cooperates. There should not be any head tilt. Patient should be opening up the eyes properly. There should be proper fixation. If the patient had a deep set eye, sometimes the slit lamp marking may not work out. So then I go for the reference marking using these devices. And I have purchased all these devices, and they are basically a waste of money. They really don't help you in most of the situations. So freehand marking in very uncooperative patients. And when I mark these lenses, these cases, it is, I may not even mark. I just remember the limbal, with a blood vessel or any pigment, and then just remember this is the axis that is referred. That is important. Now, this is a modified technique of torical implantation. It's not a modified hydroimplantation. I'm using Helon 5 to plug the two paracenteses and the main incision, and then using BSS to form the bag. So when you do that, so the lens is basically inserted into the capsular bag, and it is a BSS. So there's no question of there's a need for removing the OVD from behind the bag. And sometimes, when you try to go behind the bag, behind the lens to remove the OVD, you may land up with a PC rent, as you see here. The lenses have already been centered, so there's no decentration that is happening. So friends, torics have great potential, provided the patients are properly selected, if proper technology is employed, right toric calculator is chosen, right IL is chosen, and if good surgical technique is followed. Thank you very much.
Sir, I have a question. Excuse me, sir, I have a question. Suppose if there is a residual error of one diopter of astigmatism, how to assess where we went wrong?
Yeah, so it starts with the counseling. So many a time I tell my patients that in spite of best efforts, lens may rotate. So I use the Hoya, the eye trace. So if you put the patient on the eye trace, it shows, that whether the rotation of the lens is going to be effective or not, which direction is to be rotated, and at what axis it has to be kept. So that is what the approach that I follow. Otherwise, there is Barrett RX formula. You can go there. If you put in all the parameters, it will also tell you, how the lens has to be rotated, how many degrees it has to be rotated. Even toric result analyzer in the ASARS calculator. So I used to be using these earlier, but today I use the eye trace. That makes it much easier. Just dilate the pupil, put the patient on the machine. It gives a printout and it gives you all the instructions.
Wonderful presentation, sir. Here.
Yeah.
Sir, do you calculate your own SI still, or you use a standard centroid?
Come again?
Do you still calculate your SI and use it, or you use a standard centroid?
Actually, 8 minutes was too short for me to talk. For the Barrett toric calculator, we don't use the surgical induced astigmatism because that is an absolute number. It doesn't give the vector. So I use the centroid values. It is also a centroid which takes into account the vector, the magnitude of the astigmatism, axis of the astigmatism, and that is usually 0.1. For most of these formulas, it is 0.1 or 0.12. So I don't really have to calculate my SIA. It doesn't serve any purpose any longer.
Thank you, sir.
Thank you, sir. I call upon the next speaker, Dr. Namrata Sharma, to speak on double trouble cataract and pterygium.
Excuse me, sir. Just a second, we'll shift to the live surgery first.
Requesting everyone, Dr. Partha sir is getting ready with his surgery. And after that, Dr. Srinivas Joshi will be showing us an fascinating case, a little different this time. So everybody please have their coffee and come back to seats and be ready to be thrilled. Yeah, welcoming you all.
Who asked to go for coffee while I'm going to do the
We'll be
light
moving
surgery?
back to the OT. So we have a left eye cataract surgery case of a 65-year-old female. The vision is 624 parts, not improving. It's a nucleus sclerosis grade 2 with posterior subcapsular cataract. The IOL which will be implanted will be a plus 22.5 diopters in focus IOL.
Thank you, Dr. Stuti. So this is Dr. Deepthi here from OT, and we have with us one of the doyen in ophthalmology, Dr. Partha sir. He's ready with his surgery. So over to Partha sir for his cataract surgery.
Thank you very much. And I'm really grateful to MM Joshi Eye Hospital, the entire team, right from Dr. Joshi sir to everyone here assisting me and helping me for the surgery. So we start off the surgery and it's a routine cataract surgery. And we'll make these ports. The side ports first need to be made. And I'm using the Revalia microscope. Actually, it's a grade 2, grade 3 cataract. But with this particular microscope, everything looks to be grade 1. So the reflex is so good. So methyl cellulose before we start the Rexis. Can you give me the side port once more, please? Cornea, please. Gel. No, Rexis. Gel. So a good fill of the anterior chamber is important, and if it is nice and tight, usually the Rexis will not run out, and you can have Mataji, light nodi.
See the light node ray? Light node.
Rex itself is so good that you can exactly make out the circumference of the Rexis. No. Main port. So I'm being assisted by Mr. Shekhar and Sister Manjula. I just happen to know that Mr. Shekhar has been with MM Joshi for 28 years. So that speaks volumes of what the institution means to everybody who is in the team. So very gentle hydrodissection. This is not a PPC at all. And we can use a little bit of viscoat maybe. And then so I really do feel that as if I'm operating in my own OT theater. really a world-class theater that we have here. Congratulations to the team. And I'm using the Centurion, no, straight chop, direct chop, please. So I'm using the Centurion and we'll do a direct chop. Light nodi.
See the light now.
So tilt the nucleus a little and going to the far periphery and then getting a straight direct chop here. So creating the next chop and just separating to the posterior pole and then this semi quadrant also. So we have 4 quadrants nicely. Yes. Now we go into the quadrant mode and you can really see the fantastic stability of the system and the fallibility of the fragments as they come in. At any point, if I feel that the chamber is shallowing, we can always reduce the parameters. We'll go into the epinucleus mode now and work under. So I've taken off the side port instrument so as to give a little boost to the intraocular dynamics. And the active sentry of the Centurion machine is something that's really, really excellent as a machine. And it gives excellent stability of the chamber and it gives a lot of benefit to the post-operative results as well. So I'll take the bimanual and clean up the cortex. So again, removal of the cortex is otherwise simple. You just need to see that how the PC is behaving at this point. I think this machine really deserves a lot of congratulations, not only to to all surgeons, especially to our youngsters who use the machine with great energy, as well as the learning curve becomes very, very smooth. So
Man behind the machine is more important.
I think the teacher behind the machine is also very important. So we just need to play on the parameters and do the things in the right way so that we utilize the benefits of not only the machine but also the microscope. And the microscope has a lot of features. Irrigation. So I'm going to inject an in focus, suprafoam in focus, which is an EDOF lens. And it's one of the very nice EDOF lenses that we have now. got trapped, I think. Because got stuck. Now, Visco, please. Just, yeah, can you inject from the side? Yes, very good. Sister, inject full inject. Full inject, sister.
I
Yes.
think the trailing haptic has got stuck in the,
Yes, the trailing
Injector.
uptake has got stuck. Hmm. Yeah, stop the irrigation. Full visco inside, please, sister. Hmm.
wait.
Acha. Sister, you can hold this. Actually, no, yes, actually it has to be taken out.
To be taken out because the
There
leading
ha-
haptic.
Because
is
the
also-
leading haptic has also got it. Wait a minute. That will be, okay. Leading haptic has also got severed a little. So now we just have to cut this lens. Cut the lens and
So what instruments normally would you use to cut the lens and explant it?
so lens cutter is what is required.
Lens cutter, or one can even use long vanas if it is there.
Cutting, what do you want me to? This one to cut this. Okay. Vanessa. Okay. So do you have
So long vanas can be used, and maybe you can just cut out a wedge and then the whole thing will carousel out.
yeah. Do you have forceps, a long forceps to go from the side port? No.
Or a ILM forceps just to stabilize the lens from one side and hold it in position.
The side port? I think we will.
Do they have a micro forceps or ILM
Yeah.
forceps or even a crocodile which they use for the vitreoretina people?
I think let me increase the size of the incision a little bit.
I think some of these foldable lenses, if you increase a little bit the size, they will just, and pull them out, they'll just come out themselves only.
Wait a minute. This coat, can you give me some this coat?
Yeah, so yeah, if you stabilize it with the micro forceps, otherwise what happens is that the lens keeps wobbling while you are trying to cut it, so it doesn't get stabilized. So if you use micro forceps from one side, which could be any kind of forceps, ILM forceps or crocodile or micro forceps dedicated. So it gets stabilized and gives you a stable platform along which you can actually cut with the help of long vanas. And you don't have to cut across half and half. Even if you cut 1/4 of it and take out that little wedge, the rest of it will carousel out of the wound.
You're doing a great job, Partha. Very impressed.
So I think that this is not cutting this has to be replaced.
Viscoat.
So there are dedicated IOL cutters also, and one of them designed by Dr. Neha Dholakia, which is very good, which
Change.
helps to to explant, in fact, not cut, but explant the intraocular lenses.
We'll just try and see if it comes out. It is just about 1/4.
So it is also about the consistency of the material of the foldable
Let me see.
intraocular lens.
Forceps.
Some of them are very
Strong
pliable and they would come out, but some of them may be a little more rigid and will not be folded. I think the technique that Dr. Partha is showing is that bi-manually he is doing it and holding it just at the edge of the lens and then.
Very good. Very good. Well done, Partha.
So Partha, this much applause you would not have got for a case which you would have done normally. Which you have now got for an explanted IOL.
Yeah, put the lens. So we'll put in the same lens.
Not the
So
same lens, the same company and the same power lens.
So I think learnings from this is first is the viscoelastic and the cohesive viscoelastic is a very important thing and supporting the posterior capsule while all these maneuvers are being done. It's very important that the PC doesn't come and close up on the forceps or the scissors. And it is not necessary to cut the whole IOL half and half, as Namrata said. So even if it is half cut, so that also can swiggle out. This time we could not cut up to the half, but we could, because of the material is quite pliable, we could actually only with 1/4 of the cut we could take it out.
I think the important thing is that you have to slightly increase your incision also.
Yes.
Otherwise,
which we
through the
did.
same wound,
Yes,
it is
yes.
not going to.
Because this was a 2.2. With a 2.2, it becomes very difficult. And shall I load the lens? Forceps. This time, of course, it will go inside directly. Done, ma'am. Light nodi, ma'am.
I think, is that the chopper or the Sinsky? They've given you chopper by mistake, I think.
ಆರಾಮಮ್ಮ. ಲೈಟ್ ನೋಡಿ ಅಮ್ಮ, ಲೈಟ್ ನೋಡಿ, ಲೈಟ್ ನೋಡಿ.
Okay, so very good, Partha. You've learned their language also.
Visco, please. Visco mode.
So actually, if you put visco, then to take out in the visco mode, it becomes a little difficult. But for that, if you put the IA mode, then it will come out faster.
Okay.
So because visco tends to stay for longer period of time, and it's not, Elon, like sodium
Again,
hyaluronate will come out
ISS.
quickly.
Yes, sir.
It will get aspirated much faster than visco. So it's like this, that as far as viscoelastic aspiration is concerned, the sodium hyaluronate is the fastest, followed by your HPMC and followed by your viscoat. So viscoat is like, aspirating out another bulk of something like cortex. Okay, excellent, I think.
I think I have to thank both Shekhar and Manjula for the excellent cooperation. Immediately, all the instrument were here, and I really didn't have to ask for it.
So I think that was excellent, Partha.
Thank you very
Excellent.
much.
They didn't plan this, but then we've seen what we can.
The
face
public
sometimes,
prosecutor
yeah.
wins here, Partha.
Thank you, Chitra. Thank you, Namrata. Vigamox.
Next, after this, we are going to have another squint case in the same OT. So meanwhile, we'll shift to the 3D live retina surgeries. For that session as well, I would like to call the panelists to please come forward and take the front seats. Dr. Prashant Bavankale, sir, Dr. Vivek Wani, sir, Dr. Aditya Kelkar, sir, Dr. Sachin Mahuli, sir, and Dr. Katyayani, ma'am. We'll be shifting to the 3D live retina surgery, sir.
Good afternoon, everyone. Tuti, you're able to hear me?
Yes, sir. So to begin with this live video surgical retina session, I would like to invite Dr. Srinivas Joshi, sir, who will be demonstrating an interesting video of a persistent macular hole. This case is 65-year-old male who presented with diminished vision since 1 year. The patient had a history of vitrectomy with ILMP and gas tamponade done elsewhere 9 months back. And OCT showed persistent large macular hole of MLD 887 micron and a BLD of 1068 micron. So we decided to proceed with the novel technique of neurosensory graft. So let's go live.
Thank you, Shadma. Inverter. So first of all, congratulations to Alcon for bringing in the new Ingenuity 1.5 device software. It is the first launch in India we are doing today. I think you noticed a few of the advantages of it in the anterior segment of the cataract surgeries as well.
Hello.
Yes.
Good morning, Srinivas. Why don't you highlight the advantages for the sake of everyone?
Yes. I'll be doing that. So can you just, are you able to see the screen, the 3D screen?
Yes.
On the right side, you are able to see there are various modes. Keep showing them the modes. See, this is the tissue detail mode. This is the standard mode. And then we have capsule clarity mode. So this usually is very good for capsules, especially the anterior and the retinal ILM capsules. And then we have MIGS mode. Keep going down. No? MIGS mode, select the modes. Yeah, go next. And then you have blue boost mode for Rexus. That is especially if you want to do a trypan blue and want to do a Rexus, that is the blue boost mode. And then you have performance green. So this is basically more of the color channels which they have introduced for the ease of the surgeon, so that it helps to visualize these membranes with a less amount of dye as much as possible. So the less toxicity, better is the visual outcomes, functional outcomes. So here, this is the case of the failed macular hole, which was operated long back. So here, if you can see here, I hope you are able to appreciate the macular hole here.
Yeah, it's a large macular hole, I think.
Yeah, it's a large macular hole. Please don't change it. Let it be tissue standard. Diathermy. So immediately I'll straight away shift to the diathermy. I've made actually 4 ports just in case if it is required. So here I'll be harvesting the graft from this area. Just to make sure that it doesn't bleed. So I just cauterize, but some amount of bleed keeps happening. Laser, please. So before that, I'll just finish off the laser to that area.
Dr. Srinivas, you will be doing epimacular placement, or you would want to place
Sir, can you be a little louder?
Srinivas, Dr. Aditya here.
Yeah.
I wanted to know if you are going to place this graft inside the macular hole or
No,
epimacular.
overlay.
Yeah.
Aim 0. So I'm just trying to laser it before doing that, because sometimes if you have a bleed, then it's very difficult to laser that under the blood. So I'll just laser it off before. 42 gauge needle ready. Injection pressure 25. Okay. So once it's done, inverter. Inverter. Yeah. So here you can see I will try to raise the bleb a little bit. You can see the fluid level going underneath.
Srinivas,
Yes.
you're using a VFC system?
Yes, VFC. Okay, once it is done, then I'll use my scissors. Either you can do it uni-manual or you can do it bi-manual, whichever best suits your hand. So here I'm doing a uni-manual dissection. Okay, so once this is done, I'll just put a PFCL. Forceps. So just sliding it under the PFO.
Very nicely done, Dr. Srinivas.
Thank
Very
you.
well demonstrated.
Yes. So now we can have the IOCT flat lens.
So this diameter of the epimacular tissue would be about 1.5 times the size of macular
Yes,
hole?
1.5
Yeah.
times. Yes, because many studies have proven that the lesser the size, because the graft contracts.
Right.
So after some times the graft contracts. So if you take the accurate optimal size, then it might not do the function as and the inlay of the grafts they have already stopped. Many of the surgeons who are doing the neurosensory graft has stopped it. It's because you have to induce a macular detachment and it is more traumatic. Now we can see the placement of the graft with the IOCT here. ಏನಾಯ್ತು? Wait. Can you see this thing? One second. Can you see the graft placement?
Yeah,
No?
quite clearly,
Yeah,
yes.
yeah, quite
One
clearly,
second,
very
I'll
nice.
just show you. Yeah. You can see it on the IOCT screen there. Switch off the OCT once. I'll center it. OCT off. Yeah. Inverter. Yeah, off it is. Correct. Enough. Wait. Now you switch on the OCT, please. Now you can see the graft placement over the MAC hole.
Quite clearly seen, yes. Very nice.
Focus. I hope it is seen. You can show the camera on the right side, full this thing. If you have the 2D image there, camera, you can shift that camera this side, please.
Srinivas, it's seen very
Very
clearly.
clearly seen,
Very
Srinivas.
clearly seen.
Very
Very
beautifully
clearly seen,
seen.
na?
Yeah.
Okay. So this is the IOCT screen. I don't know if you are able to see that. On the side view, are you able to see that?
Yes.
Yeah.
Yeah. So you can see the placement of the graft. It's almost covering it and it's almost inside, nicely covered. So I'll just switch off the IOCT. Remove. Saline, visco. See here, the tissue details can be seen very nicely with this tissue detail of the Ingenuity. It gives you a little realistic view, or it can be, you can say, a little added colors, little bit, but definitely you can see a nice view of that. Inverter, please. Can I have the FAX? FAX.
Dr. Srinivas, any special tips for all of us how to prevent dislodgement of this graft
Yeah.
when you're removing this PFCL?
So careful. So I just try to FAX. Yeah. So now you can see here, I'll just slowly start first filling with the air. So once I do that, I slowly go into the bubble and try to break the interfacial tension between the bubble and the air. I'll just show that.
So you're trying to aspirate the fluid that is trapped between the air and
Yes,
PFCL
yes, yes, yes.
so that this fluid ultimately doesn't dislodge the graft.
Hopefully it should
Yeah.
not. Yeah. So once I break that interfacial tension, then slowly I tilt the eye. You can see here and aspirate it superiorly. Yes. So now you can see the graft, it's not moved at all. So this is the final this thing, and I'll just go ahead and put some more fluid air exchange, please. So once it is stuck, it does really good. I just put a gas in these cases because the patient is able to position well.
So you use an active aspiration to remove the last part of the PFCL as well,
Yes, yes, yes.
rather than passive.
Yes.
What about the small pocket of fluid which is at the posterior pole? You would leave it there at this point of time?
No, yeah. The gas will take care. It will do a tamponading effect and it should take care.
Okay, wonderful.
So now you can see it is totally plugged. If it has to move, it would have moved with the aspiration itself. If it is not moving, then that means it is really stuck at the edges. So once it is stuck at the edges, then I immediately go ahead and put in the gas C3F8, please.
Wonderful.
If it had moved, then I would have gone in and put the oil in this case. But since I don't see it moving, I just go ahead and put 16% C3F8.
Wonderful, Srinivas. The main culprit, as you highlighted, is a fluid. So
Yeah.
the fluid interface, if it is not there, it generally doesn't move.
Yeah, it usually doesn't move. The advantages over the conventional ILM flaps is ILM flaps are thinner. These are thicker. So it doesn't move that easily. Second thing is it causes a compartmental kind of effect. That means it plugs the fluid between the vitreous cavity to the macular hole, keeping the hole dry. The third thing is there is something new which they have come up is ectopic synaptogenesis. So this ectopic synaptogenesis is where the bipolar cells of the host tissue gets mixed with this graft. The photoreceptors keep moving with the graft. 1 second, just a bit. Good. Injection.
In post-op period, have you seen any contraction of the tissues and all that?
Yeah, I'll be explaining that, sir. 1 second. ಶೆಟ್ರ ಆಪರೇಷನ್ ಬಾದ್ ಚಲೋ ಆಗೈತಿ ಡಬ್ ಮಲ್ಕೋಬೇಕ ಹೇಳ್ಕೊಡ್ತಾರ ಹೆಂಗಂತ ಹೇಳಿ.
Wonderful surgery, Srinivas, as expected. Big round of applause for every Srinivas there.
Dr. Srinivas, excellent surgery.
Thank you, sir.
Very nice.
Come here. Hello. Yeah. So now you were asking about the tissue contraction. So the tissue, come here, Siddharth. So I would like to first thank my team, Siddharth, the Retina Fellow from Jaipur. And I have a wonderful team assisting with me, Mr. Vittal, Mr. Shanta, Mr. Shobha, and all the Alcon team here. Guru Prasad is here, Vishwanath and Girish all are there. Thank you very much. So I think, who asked that question? Sachin sir asked that question about the tissue contraction. Yes, tissue contraction is known. That's why we take the size of the graft is slightly larger, so that even if the tissue contracts, so it will optimally fit the size of the hole. That's why we take 1.5 mm, 1.5 times the size of the hole, as Dr. Aditya mentioned it. The second thing is, we have done around 20 cases now, and we have seen 62.5% of improvement in these kind of failed MAC hole cases with the neurosensory graft technique. So how do you expect the visual outcomes to be there? The recent theories which says that the bipolar cells of the surrounding macular hole, they tried to make a synaptogenesis with the photoreceptor cells of the host tissue. Thereby, you can see in most of these MAC hole where they get the tissue gets integrated inside the MAC hole. It also acts like a bridge, like how the ILM, it acts like a scaffold for the periphery to move in and close the hole. This also acts similarly like that. Along with that, they have also seen the outer retinal layer recovery. The recovery of the outer retinal layer is something which is new, which we are finding in these cases of neurosensory grafts, which is probably useful for the functional outcome or the vision which is gaining back in these kind of cases, because we saw visual improvement in 62.5% of the cases. The rest 37 cases, they had almost similar vision, but the vision did not drop down in any of these cases of the neurosensory graft. The another hypothesis, they also have the RPC, that is the retinal progenitor cells, which also helps in differentiating between the photoreceptors and the ganglion cells. So these are the various advantages of using the retinal autograft as compared to the ILM grafts. But my technique would never be an autograft in the initial, in any of the extra large macular holes. I always go in for the inverse flap technique. Only if the failed macular holes where we are not able to get a sufficient ILM or a good sheet of ILM, then this is a very good technique to have it, because we are already seeing a lot of visual improvements in these kind of cases.
Wonderful, Srinivas, wonderful. So any other input now?
Srinivas, very nice, excellent presentation, excellent surgery demonstration.
Thank you.
So now shall we go ahead with the talks?
Please, sir. Thank you.
Okay.
Thank you very much.
So before we move on to the squint case, I would request SV Koti sir to please welcome Namrata Sharma ma'am for her talk.
A brief introduction of Dr. Namrata Sharma. She is a postgraduate from Dr. Rajendra Prasad Institute, Delhi. She has done her fellowship from Moorfield Eye Hospital in London. She is currently the regional secretary of Asia Pacific Academy of Ophthalmology. She is the honorary general secretary of All India Ophthalmic Society, AOS. Her keen areas of interest are corneal transplant, DALK, DSEC, DMEK, the anterior segment reconstruction procedures, ocular surface surgery.
Okay. Thank you. Thank you. I would be starting my talk, and I think this is the old one. Santosh is the General Secretary of AIOS. And anyway, so I would be talking to you about cataract surgery in corneal disorders, and there are no financial or proprietary interests. Is this my laptop? No, this is not.
Your laptop is not connected, ma'am. You can use this laptop.
Okay. So I think the bigger question always would be whether you would want to do cataract surgery with SICS or phaco, or you want to combine it with corneal transplantation. And you can do SICS or phaco depending on what you are well versed with. And the factors which would determine whether you do single stage or combined procedures would depend on the type of the opacity, the location of the haze, the expertise of the surgeon, the availability of the donor corneas, and visual requirement in terms of risk-benefit analysis. So it is always important to plan your incision so that you plan it in such a way that at least one of the cornea is clear. And there could be several conditions like this, phacoemulsification, which needs to be done in a case of pterygium. And it is important when you look at the pterygium, you have to see the area, length, width of the pterygium, height of the pterygium, and invasion across the cross-sectional area. And this is just to show a case of cataract with pterygium. You can see that there is some amount of flattening which is there. And post-surgery, you can see that this flattening actually decreases after you remove the pterygium. And this is to show the case in which the pterygium was there and white cataract is present. So as stage 1, we are removing the pterygium because the pterygium is really wide and it is encroaching into the corneal area. So after we actually do the excision of the pterygium which is done, this area is cauterized, and then subsequently a graft is taken, conjunctival graft is taken, and this is then placed over there. Subsequently, 6 weeks down the line, we can take this case up again for toric intraocular lens implantation. And in this, the regular astigmatism is taken care of, not the irregular astigmatism. The trap and blue staining of the anterior capsule is done, followed by doing, just as you would routinely do a phacoemulsification, followed by hydro procedures, cortical aspiration, and then intraocular lens implantation, which is done in the bag using a Callisto to see the axis of the toric intraocular lens. So there would always be a dilemma, especially in these cases where you have atrophic pterygium. And the dictum is that if the astigmatism is not there, then in that case, even the atrophic pterygium, you can do a simultaneous cataract surgery with pterygium excision, such as in this case. The pterygium can be done earlier or can be done later. And in this case, it was done later after doing the phacoemulsification and foldable intraocular lens implantation. The pterygium is just excised, and this can be because it is atrophic, the conj graft in this case was not planned. Now, sometimes you can have a case like this, which is a double-headed pterygium where the pterygia is excised and you need to put amniotic, you need to place amniotic membrane graft as was done in this cases. It is quite wide also, and there is also a cataract which is present. Diamond burr can also be used to address the remnants of the pterygium. The other side pterygium is now being removed and excised. And because a large area was involved in this case, so amniotic membrane was used. This is the burr which is being used to smoothen out the area, and then amniotic membrane is being used. And subsequently, we can do a cataract surgery in this case. And generally, it is said 6 weeks, but there are studies which have shown that up to 6 months, one should take care of this. So the best surgical strategy for concurrent cataract and primary pterygium is that if the pterygium is large, wide, or deep, then in that case, it is strongly recommended that you should do it as a staged procedure. But if it is atrophic, you may do it simultaneously. Now, IOL considerations for corneal disorders, generally we do monofocal. We take a keratometry which is standard. Biometry can be done using ultrasonic B scan because IOL master in these cases may be difficult to do. Now, just to show some of the cases, this was a case of chemical injury with cataract. And as you come underneath that opacity, you go in one go, stain it with a trypan blue dye, do phacoemulsification, irrigation, aspiration, followed by foldable intraocular lens implantation, which is easy because you can actually see at least 3/4 of the cornea. Then this is a case of one-eyed patient, healed keratitis, who didn't want a corneal transplant. And in this case, it's a hard cataract, so staining with the trypan blue dye is done. Again, as you come underneath that haze, you go in one go, because if you don't, then you lose the edge of the rexis there. Then your rexis is slightly eccentric because there's an optical aridectomy there. Crater is also eccentric, and retro illumination is on, so that as you do phaco in situ, that means you chop, you eat, you chop, you eat, and the red glow gets better and better. And as this red glow gets better, you can actually see what is the nuclear fragments or the grayish fragments, and then subsequently do irrigation aspiration. The second instrument helps you to take these fragments from the area of haze into the area where you can visualize them. And then you can actually also see the edge of the rexus where this intraocular lens is implanted. This is what we published for Steven Johnson cases. And again, these cases can be tricky because you can't do a corneal transplantation in these cases because they are high risk. So it is important that you expand the pupil. Subsequently, you by using the nylon hooks, do a temporal phaco, use endo illuminator inside or outside, depending upon where the visualization will get better or clearer, and subsequently implant an intraocular lens in this and remove the nylon hooks following this. At times, you may even have to use an endo illuminator with the chandelier. So this is a post-PK cataract. And in this, nylon hooks are used because the iris is, there are posterior synechia which are present. Again, you keep putting viscoelastic because it gets cleared for that moment of time, helps you to do the capsulorhexis. So the capsulorhexis is done, followed by hydromaneuvers, irrigation aspiration, then phacoemulsification, and then endo illuminator is being used here. And also we use chandelier, and that helps to actually internally reflect your nuclear fragments and makes the view a lot more clearer. So one can then can then implant the foldable intraocular lens implantation can be done, and the nylon hooks can then subsequently be removed. And sometimes when it's hazy, you can actually make out in the intraop OCT microscope that the PC is quite intact and the foldable intraocular lens is implanted. So these are some of the post-operative results. In SJS, the visual acuity from counting fingers to 612. Then this is again improving. And likewise, this is again improving. These cases are difficult and they may be tricky, but patient does become ambulatory. And I think that is what we are looking at. Now, I think even flax has a role to play because there would be corneal haze, and flax is going to do capsulorhexis and also going to make the chops, although not all of them. In flax, you have to do fill in the blanks. So the capsulorhexis would be there, but it will not be complete. So you have to complete it, and that can be done manually, as well as the chops. So if you look at this, the rhexis is not happening here because of the haze which is present. So you can complete the rhexis manually, and all the chops, the rhexis is not complete here, but all the chops, again, the chop again here is not complete, but you can still do it because of the fact that you have to just fill in the blanks and complete the case subsequently. So this I will not show, but I would just like to highlight that it is possible to combine it with deep anterior lamellar keratoplasty and phacoemulsification. So the patient does get a visual acuity of 612 as you do layer by layer deep lamellar dissection and cataract surgery simultaneously. And this case where DSEC triple was done, that means the epitheliorhexis was done because you have to remove the hypertrophic epithelium. In one go, the second rhexis was your desmetorhexis, which was then subsequently done. And the third rhexis is actually your anterior capsulorhexis, which is done. It is quite hazy, but the endothelium here is compromised. So the phacoemulsification is done. And then this is combined with the DSEC procedure. After implanting the foldable intraocular lens, the DSEC lenticule is taken, is placed intracamerally, and then subsequently air bubble is instilled and the graft is centered. So you do have good results. This case was referred for full thickness corneal transplantation, but did well with the sutureless transplant. And of course, you can also do DMEC triple, such as in this case, where the Descemet's membrane graft has been done and phacoemulsification simultaneously has been done. And this is how it looks at the end of 6 months, where you can't even make out that a graft was ever done. So this is the algorithm that we published, and this is published in Journal of Cataract and Refractive Surgery as to how these corneal opacities are to be dealt with, whether doing phacoemulsification alone or doing combining procedures. And this algorithm, which we normally follow at RP Center as well. So to conclude, it is important to find, see, create, and fill the gaps wherever you can. And it is a challenging path to do phacoemulsification in the presence of corneal disorders, but it is possible to do it with the various aids that I showed you. And at the end, I would like to invite all of you on behalf of All India Ophthalmological Society to Asia Pacific Academy of Ophthalmology, which is going to be held April 3rd to 6th, 2025 at Yashobhumi. Thank you very much for your kind attention.
Madam, I have a question. Suppose pterygium with hypermature cataract, what is the waiting period? Since there is a risk of lens-reduced glaucoma, how quickly we can operate upon the cataract?
So if it is a pterygium and if it is a very big pterygium, if it's a atrophic pterygium with hypermature cataract, it doesn't matter. You can remove the atrophic pterygium, go ahead and do a cataract surgery. But if it is a large pterygium and then you are sure that the patient is not going to follow up also, so in that case, you can do a simultaneous procedure. But one thing has to be clear, that there would be some amount of astigmatism which will be pterygium induced. And also the IOL power, you tend to make the patient more myopic. So the IOL power also has to be titrated likewise. But yes, in almost 16% of the cases in one study, they showed that they would go off mark. But in most of the cases, if it is a hypermature cataract, I'm not saying the patient really wants 6x6 vision exact, but the patient, would with spectacle correction still be able to be ambulatory if you have simultaneously done a pterygium excision and a hypermature cataract both.
Thank you, madam.
Thank you. Yes.
The next speaker will be keynote address by Santosh Honawar. He's a well-known figure. He has trained himself in RP Center and Wilms Eye Hospital, Philadelphia, established oncology in LV Prasad Eye Hospital, was associate director of LV Prasad, established residency program, currently heads oculoplasty and oncology center for sight and CFSE education. Awarded by Shanti Swarup Bhatnagar Award by Government of India, Jerry Shields Award by Asia Pacific Academy of Ophthalmology, and first Indian to receive Lifetime Achievement Award by American Academy of Ophthalmology in 2019, Honorary Fellowship of Royal College of Ophthalmology of UK in 2020. Now he is the editor of Indian Journal of Ophthalmology. No, okay. The past editor. No, the paper he was given is, the paper says he is going to talk on tumors of the ocular surface.
Thank you very much, sir. I thank MM Joshi Eye Institute for this wonderful opportunity to be with you. I'll be talking about management of ocular surface tumors, how oncological principles optimize the outcome. We're all very good surgeons, but sometimes our surgeries do fail and patients tend to have local tumor recurrence and regional metastasis, etc. So it's such a situation, how to minimize local tumor recurrence is a question. If you simply adhere to these oncological principles that are being shown on the screen, that your diagnosis should be accurate. When using topical therapy, you should be sure of the diagnosis. When you plan surgery, we have to have edge as well as base clearance. I stress on base clearance at surgery. Then give due respect to histopathology and provide histopathology guided adjuvant therapy. And if there is scleral or corneal stromal involvement, do brachytherapy. Imaging has revolutionized the diagnosis of ocular surface tumors. These are 4 cases with nevus. But you may have a diagnostic dilemma in certain situations. You may not be able to differentiate a nevus from a melanoma. In these situations, we have a clinical checklist, which sometimes may not be adequate. You may still have a diagnostic dilemma. Then use anterior segment OCT. Nevus are supposed to be spongy, whereas melanoma is solid. If you find microcysts and macrocysts within a particular pigmented lesion, you can be sure that it is a nevus and not a melanoma. That's the clinical test that you do. What if a nevus has transformed into a melanoma? This was my own patient who had left the city for 10 years. and came back with a new growth at the edge of a nevus. This was the nevus that he always had, and that was a new onset lesion that had developed in the last 6 months. When we did imaging, we found a solid area. We also found an area with cyst. The area with cyst conformed to the nevus, and the area that was solid was the new onset melanoma. And on histopathology, you can see this nice zone of transition of a nevus into a melanoma. So when you have a patient who has a changed clinical manifestation or a picture of a pigmented conjunctival lesion, you can use ASOCT. For ocular surface squamous neoplasia, we have this triad of signs: keratin, abnormal vascular pattern, and rose Bengal staining. All of them put together are highly sensitive and specific for the diagnosis of OSSN. But you still have a diagnostic dilemma. You can use anterior segment OCT, hypertrophic corneal epithelium, which is hyperreflective, white, which abruptly truncates with a snout-like ending, is diagnostic of OSSN. Topical therapy for ocular surface squamous neoplasia has come in a big way. We can use topical chemotherapeutic drugs, which is mitomycin and 5-fluorouracil, or topical immunotherapy, which is interferon alpha 2b. These are the drugs and dosages. But basically, when we use interferon alpha 2b, we use it in 3 modes. One is for complete tumor control. Second is to reduce the tumor, that's called immunoreduction. Third is to make the ocular surface amenable for its own immune protection against new onset tumors. For small tumors which are located in 1 to 2 clock hours, such as this, topical therapy works very well. For tumors which are recurrent, again, topical therapy works very well. Corneal OSS is a specific indication for topical therapy. This is the area where my cornea colleague had done a biopsy, and that's the exact area where there is a residual corneal scar. Rest of the tumor, of course, was taken care of by topical therapy. Tumor at the graft-host junction, which can happen in patients with xeroderma pigmentosum. This was a patient where this was his 3rd graft, other eye was thicical, and unfortunately, there is a tumor at the graft-host junction that could be treated easily with topical interferon alpha 2b. Tumor which are about 6 to 7 clock hours occupying the limbus, where if you do lumpectomy, you have a chance of limbal stem cell deficiency. There again, to provide scarless healing, you can use topical interferon. Diffuse tumors like this, tumors which are flat, placoid, respond very well to topical therapy, whereas tumors which are tall like this are more amenable to surgery. So this patient who had almost the entire ocular surface involved with a diffuse tumor could be treated with 3 months of topical interferon, and it resolved well. Immunoreduction is a principle where if you have a large tumor like this, it can be reduced to a small residual before you do your surgery so that your ocular surface damage is minimal. How does it work? If this is the limbus, that is the epicenter of the tumor, because OSSN is a tumor of the limbal stem cells. Around that invasive tumor would be a zone of carcinoma in situ, severe, moderate, and mild dysplasia. All of this would go away, and what would be left is that invasive squamous cell carcinoma component that you would finally operate. So immunoreduction is a real concept. Immunomodulation is used for xeroderma pigmentosum and patients with HIV seropositivity, and it can prevent local tumor recurrence. Now, topical chemotherapy is very good, but there are certain situations where you have to use injectable chemotherapy or immunotherapy. This is a patient where both the bulbar as well as the palpebral conjunctiva involved with tumor. Their topical therapy itself would not work, so we inject interferon alpha 2b periocularly around the tumor and also give topical therapy for eye salvage. Otherwise, this was exenterable. 50% of these patients who can undergo exenteration can be saved by this technique. Then when we talk about surgery, we always talk about excision with tumor-free margins and alcohol-assisted keratoepithelectomy for the excision edge for the corneal epithelial component and excision edge cryotherapy. Edge determination is very easy. For example, this tumor, you can easily see that that is the edge of the tumor. But what about the base? Base is opaque. You cannot see the base with slit lamp evaluation. So for base specifically, you have to do imaging. Otherwise, you would not know whether the particular tumor is involving the corneal stroma or anterior scleral lamellae or not. This patient, there is this bubbly tenons right under it. So obviously, this patient has a tumor involving only the conjunctiva. Your plane of dissection would be episcleral. Whereas this tumor, you cannot see the base, but you can see that on UBM, the the cornea is played there. There is internal reflectivity within the corneal stroma, indicating that there is stromal involvement already. We often take this large conjunctival diagram for us to localize the tumor after having given peribulbar block. Sometimes the smaller components of the tumor become less distinct. These are the results of surgery. Surgery works very well. But beyond surgery, patients who have scleral involvement or intraocular extension were earlier exenterated. There was no other option available for them. Now we have an option that is called plaque brachytherapy. So how exactly do we do plaque brachytherapy? We dissect the anterior component of the tumor, not like dissect on the sclera or under the sclera. Retain the sclera for whatever it's worth, but sclera has tumor. That scleral base has to be treated with brachytherapy. That is how the technique works. This is called secondary plaque brachytherapy. So excise the tumor and then do plaque brachytherapy after confirming on histopathology that sclera is indeed involved or the base is indeed involved. You can see the results of plaque brachytherapy secondary. But there are some patients where there is corneal stromal melt already, but this patient has useful vision left. If you were to try to excise this tumor, you would leave a gaping hole in the sclera behind, which may not be easy to repair at all. You cannot do a keratoplasty or a scleral graft in this situation. So you just do a biopsy from a safe area, confirm the diagnosis on frozen section, and immediately apply plaque directly on top of the tumor. This is called primary brachytherapy without doing an extensive surgery here. And it works very well. This was a conjunctival melanoma. The scleral component could easily be treated with brachytherapy without any sclerectomy. Melanoma with intraocular extension, you can see these are the ciliary processes. That is through the sclera, the tumor has extended, patient has good vision and we wanted to retain it. Again, this patient was operated, tumor was excised and brachytherapy was done and the eye and the vision could be salvaged. Results are impressive, 90% success rate, and this has been recently published. Last bit is about target therapy, which could be local targeted therapy with rituximab injection around the tumor for lymphoma of the orbit. And for conjunctival melanoma, we have various agents. There's one recent patient where nivolumab was used for regional lymph node metastasis, and the patient had extensive PAM with melanoma recurrence, and that completely went away after 3 months of treatment with nivolumab. So target therapy is real and it can be used for the management of conjunctival melanoma. So in conclusion, I would say that application of all these newer modalities and oncological principles definitely helps reduce the tumor recurrence. Thank you so much. Any quick questions? Thank you.
Thank you so much for the talk, sir. So now we move on to a live 2D surgery of a screen surgery. We have a magical surgery to demonstrate. Here, as we straighten the upside down world of a child. So here you can see a gross head posture of a child. The child assumes the head posture even when picking up the lenses or playing with the toys or even while communicating or walking or talking. So every parents can relate waking up in the middle of the night by your child with such a head posture is really scary. So the parents were all worried. They went to a pediatrician, they went to an orthopedician. No one could find the root cause. They were all worried. And finally, they came to our department of MMJ Eye Institute. The child was diagnosed with right superior oblique palsy. As the child had a very gross head posture, usually we do superior oblique tuck with IO recession, which is a 2 muscle procedure. But here the child was very young. We thought, why not? Why to operate 2 muscles? So we went ahead with a single muscle surgery, that is inferior oblique anterior nasal transposition. Usually this surgery is done in acquired superior oblique palsy, and we were the first one to try it in a congenital superior oblique palsy in a pediatric age group. So you can see the post-op. Voila, the child is orthophoric with no head posture. The child is comfortable in the day-to-day work activities. So today we demonstrate, we have a surgery. Our mentor, Dr. Deepti Joshi ma'am, will be demonstrating a child, this similar procedure in a child with right eye esotropia and hypertropia. As you can see in first image, there is a superior oblique underaction and the inferior oblique overaction. So over to you, ma'am.
Am I audible?
Yes, ma'am.
Good afternoon, everyone. So as was mentioned by Dr. Sheetal, Today we would be demonstrating a case of inferior oblique anteronasal transposition. So what we are going to do is, the inferior oblique is usually, I have just done peritomy and kept. Inferior oblique is usually lateral. Now we will be shifting this inferior oblique from the lateral side to the medial side. So we are just changing the whole course of inferior oblique muscle. So before we go with any inferior oblique hooking or dissection, what is mandatory is you visualize the inferior oblique. This is the inferior oblique muscle. If you can see there, the fleshy mass. Never hook inferior oblique blindly, because inferior oblique is very closely attached to, it is very closely related to the vortex vein. Can I get the scissors? And the macula. So we go ahead with the dissection. We have to isolate the inferior oblique muscle first. I have with me for assistance Dr. Kalyani, who happens to be a fellow in Department of Pediatric Ophthalmology at our institute. And with me is Manjula. I think her introduction has been already given by Partha sir, so she doesn't need further introduction. So if you can see here, this is the bare sclera. Till you see this bare sclera, never complete your dissection of inferior oblique muscle. That means you have left behind some fibers of inferior oblique. That means later you may have a residual inferior oblique overaction. So this, now I pass the Green's hook and complete my isolation of inferior oblique. This is the inferior oblique muscle. Now I take a suture. Inferior oblique muscle never gets lost easily. I think this surgery I have learned from my mentor, Dr. Krishna Prasad sir, and he usually releases the muscle and then takes the suture, because muscle is never lost. Wipe the lens, please. It's fogging. This muscle is never lost, but I take the suture and I disinsert it. I do the opposite. So both can be done simultaneously together, any procedure. So now, once I've taken the suture, I disinsert the inferior oblique muscle. So it is isolated. We keep it in the side. Now, don't pull it too much. Now I isolate the inferior rectus muscle. Retractor. So this is inferior rectus muscle which has been isolated. Now I take, don't pull towards you. Yeah, keep it this side. Now I take the inferior oblique muscle. I pass a needle holder. This is the crucial step when I'm doing an inferior oblique anteronasal transposition. Chin up, chin up. So I hold the thread. Okay, 1 minute. And I bring the inferior oblique to the other side. So this step takes a bit of time because we need to, can you wipe the lens? I'm again having blur. And now I take the suture. Just pull this slightly on that side towards you. No. Pull it like this. Yes. And now the inferior oblique has been shifted from the lateral to the medial side, and about 1 millimeter or 2 millimeter lateral and 2 millimeter inferiorly, I attach the inferior oblique muscle. So the muscle which was lateral all this while becomes medial. So it takes care of intorsion, which is absent in SO palsy. It takes care of hypertropia without causing an anti-elevation syndrome. If you need to tighten it, you can take one more bite. That's it. So the whole of the inferior oblique is now attached. So this completes our case of inferior oblique. So this is the inferior rectus. This is the oblique which comes below and gets attached here. So this takes care of all the three procedures. So in any case of SO palsy, the most commonly done technique previously was superior oblique tuck. But superior oblique tuck, many people have a problem with isolating superior oblique, and just superior oblique tuck may not be sufficient many times. As additional inferior oblique procedure may be needed. So here, just by doing this procedure, we can take care of whole of the head turn, hypertropia, and the torsional diplopia part also. So with this, we wrap up our live surgery. Any doubt from the panelist side over there, we would be ready to take.
Dr. Deepti, this is Dr. Mahesh here.
Yes, sir.
So what are the chances of recovery?
100% recovery we have noted in the past 2 years since we have started noticing.
Oh, how many cases you have done, madam?
We have done about 15 cases of congenital superior oblique palsies. Acquired, we have done many, and it has been used in acquired for quite a long time, but nobody had used it for congenital part. So we.
Your surgery was wonderful.
Thank you, sir.
And meticulous also.
Thank
so
you.
what is the approach, like landmark you take to identify the inferior oblique, sir?
Normally, I go by fornicial approach, sir.
Okay.
So I just take an inferotemporal incision, and we can just leave this for time being. So, and I go about 8 millimeter posterior, 8 to 9 millimeter posteriorly, as posterior in fact as possible. And between the lateral and the medial rectus, I mean inferior rectus, we go and hook it. It runs actually like a band-like fleshy mass.
Yeah.
The only thing is that first visualize, never hook it blindly is the one thing. So visualize it and then hook. Here, because I had to show it, I had opened up limbus. Otherwise, normally we open it by the
It
fornicial
was a
approach.
wonderful surgery and clean and neat.
Thank you, sir. Thank you.
Nice surgery.
Thank you. Thank you, sir.
I call upon the next speaker, Dr. Arvind Moria, talk on pterygoBCL, a novel, no glue, no suture, no recurrence surgery on pterygium. I want to introduce Dr. Arvind Kumar Moria. He is a professor of AIIMS Hyderabad. He is the first Indian to win Ophthalmic Star Awards at Amsterdam ESCRS 2021. He is the first to receive the AIOS Senior Academic Achiever Award in 2021 and 13 Oriation Awards. So he has 700 international and national presentations, 100 international and national presentations. He's a
Thank
national.
you. Thank you, sir. Thank you so very much. So good afternoon, everyone, and thank you, MM Joshi Eye Institute, for giving me the opportunity, and all the organizers. So my talk is on Make in India innovation, that is a pterygoBCL, that is zero stitch, zero recurrence, zero glue pterygium surgery. And there is no stitch required, no glue and no plasma blood. And pterygium is gone forever. So it is basically is a large soft scleral bandage contact lens. Okay. Yeah, and please reset the timer also. Yeah. So it is a pterygo BCL, right? So there is no plasma blood or stitch or glue is required, and pterygium is gone forever. And out of 300 cases we have done in 1 year of follow-up, so there is no recurrence also. So it is a large 21 millimeter diameter hydrogel bandage contact lens, and you compare with the other that is 14 millimeter, and it is a very large diameter of 21 millimeter. This is how it comes, and let's go directly to the few of the surgeries. So routine excision of the pterygium, and then clearing the cornea. Then measurement is very important for the right size of the graft. And then marking of this graft, and now it is totally separated. Now it needs to be placed on the bare sclera. And a little bit of acupressure is required to fix it over this bare sclera. And now placement of the this. So it fits perfectly. So it's a very large size, so we need 4 hands for this. So the assistant need to help us in the unfolding and placing it over the graft, as well as the area from where we have taken this graft. So you can see it is covering all the 3 areas. And if some air bubble is there, there is no problem. It will get absorbed. And we can still do the maneuvering after putting this BCL. So this is the maneuvering after putting this BCL. And the surgery is over. And this is the first day. And this is the 7th day, and it needs to be removed after a week time. So it covers all the 3 areas, donor area, graft, as well as the corneal epithelial defect area very well, and no suture is required. And it can be also used in other conditions. It's not moving forward. Yeah, and the surgical time is very less, 5 to 10 minute surgery. Hardly takes any time. So it's just cut and paste and cover. Yeah, and these are the other indications like keratoconus, pellucid marginal degeneration, Terrian, archaeis, filamentary keratitis, recurrent corneal erosions, spheroidal degeneration, post-PKP and post-corneal trauma scars, iris defects also, cosmetic, PRK, LASIK. We also have this power BCL having the dioptric strength. So in case of aphakia, it's working very well. Also in pseudophakic bullous keratopathy, it's working very well. So thank you so very much for giving me the opportunity. I finished before time.
Sir, the size of the contact lens is a standard one, or depending upon the size, we have to change it?
I couldn't get your question, sir.
The size, the
Equaling
diameter of the contact lens is a standard one, or it is, there is a different size for different size of graft?
Regarding the aphakic patient,
Contact lens
size is 21 millimeter in diameter.
It is standard one for any pterygium surgery. Same graft is same contact lens is put.
Yeah, it is for all type of surgeries. Yeah.
No,
Same.
irrespective of the size of the graft.
Size of the glass.
No, you
Yes.
No,
Yeah.
no,
Even yes.
No, if graft
I
is
got
big,
yeah. Finally, I got your question. So even in cases of double pterygium, it covers very well. Even the large graft size, if you have taken, so it covers that area very well, without any problem. Yes. Thank you. Thank you so very much.
Quick 15-minute live surgery of epiretinal membrane peeling. And after that, we have a short award ceremony. We'd like to felicitate Dr. Santosh Honavar and Dr. Namrata Sharma. I'll be explaining to you why. So now we have Dr. Apurva operating a quick ERM peel. I request Rachna to please go ahead with the case details. Okay, I think it's taking. Can we switch over to the 3D OT, please? OT number 3.
Apura ma'am,
Hi.
we are with you.
Hello, everyone. I've started doing the case. I thank Shilpa ma'am for doing the FACO and IOL part of it. And this is a very thick ERM, like you can see. I extend my deepest gratitude to my mentors, Dr. Guru Prasad and Dr. Srinivas Joshi, for making me worthy of doing vitrectomy live. Thank you. I also thank my scrub nurse, Mrs. Shanta, and my assisting surgeon, Dr. Siddharth, my floor nurse, Mr. Vittal. Thanks for all the supporting staff from Alcon and the software guys, Ingenuity. They've made very good updates to the software. IVTA, please. I've finished most part of the core vitrectomy. I'm going to put IVTA now. Not going in, sister. Could you change the needle? Yeah, now it's gone in. So I've injected about 0.2 cc of IVTA and I'm going to wash off the excess IVTA now. Also using the assistance of IVTA to clear off some of the peripheral, mid-peripheral and peripheral vitreous. Yes, now you can see this clearly delineated posterior vitreous. Yes, and you can see that the hyaloid is poised for getting detached. Okay, no problem. We can try clock hour by clock hour, the PVD induction. Sometimes it doesn't come off very easily. So we have to detach it meridian by meridian. The nature of the ERM is suggestive of a very sticky posterior hyaloid. So I was expecting this, that it's not going to be a very straightforward PVD. Yeah, you can see that the shearing force, now the PVD is complete. I hope it was appreciated on the screen that the PVD is completed. Because the shearing force on the disc capillaries, you can see a small ooze from the disc, but it really doesn't matter. It's a very minor ooze. So I'm going to proceed with the removing of the posterior hyaloid. And I'm going to proceed till the anterior extent of the PVD. I welcome the panelists to pitch in with their comments if
Wonderful.
they have any.
Apurva, Sachin here. Wonderful PVD induction.
Thank you,
It was
sir.
very well demonstrated.
Okay, can we have forceps? So I'm not going to inject blue at this point because I can see that the ERM is quite kind of very thick, and I'll be probably able to find a cleavage plane to. 1 second, don't fiddle with the focus. Yeah. Can we try on some of the fancy Nginity filters? Yeah. ILM, you showed me, no, something about ILM mode. Yeah, this is the blue boost, is it? Okay.
No, Apurva, you try the yellow mode there. It
Okay.
increases, the yellow always increases the contrast sensitivity.
Yeah. Well,
Yeah,
I think the original was better. Let's go back to tissue detail, or maybe even the standard.
This is better.
Yeah,
no.
the tissue detail is better.
Yeah, tissue
Yeah.
detail.
So these are the new updates on the platform. So I am just getting introduced to it. This is the first time I'm using it. I think they updated it today morning or maybe yesterday. So let me see where I can find the cleavage. So alerts Bedama. Yeah. So here is a cleavage. There's a retinal fold underlying that. So I should be careful not to pick up the retinal fold. And the ERM is very thick and it comes off very easily. So, yeah.
Nice. Very nice.
Cutter, please. Thank you. Now, this is a very folded retina. Probably this ERM has been there for a long time. So, actually, originally I had planned a subretinal BSS injection for this case because these are chronic retinal folds. And if I make the posterior retina bullous, it will actually get rid of the folds. So I've discussed with techniques with Dr. Srinivas, Dr. Guru Prasad, and Siddharth. Can we have the 38 gauge? Or let's stain first. BBG, please. BBG and flat lens. Yes. So I'm going to see how much of the ILM gets stained. And then we'll go to more unconventional steps. Yeah. Scraper also.
Are you planning to peel the ILM also?
Yes, sir. Because these retinal folds demand an ILM peel also. We
They
want to
usually
remove.
settle down well within over a period of time, I think.
I'm sorry, sir. I can't hear you.
No, these folds usually settle down well over a period of time.
Yes, sir. Yes, sir. It will settle. Let me.
I feel it's better to peel the ILM because the regrowth of ERM is much less if you peel the ILM.
Yes.
So that is one.
Flat lens. So ILM definitely would be, I mean, it's highly recommended that in these cases with chronic macular folds, ILM has to be definitely peeled like Vivek sir just said, Vivek sir just said. So these are the cases. No thanks, no need for bud. It's centered. Yeah, it's pretty well centered. Now I'm using a macular lens to get a better view and clarity of the posterior pole. Yeah. Okay. Invert aitu. Standard, please. Yes. Yeah. Let's see. I think the ILM has come off with the ERM peel, but let's see. Scraper, please. So I'm going to use a nitinol loop now. And see if there's any residual membrane or ILM that can be scraped.
If there is no ILM, we can just put in some gas and have prone positioning, and with time, these folds will settle. This retina is also very thin, like we can see. So if I manipulate too much, even with the scraper, it is liable for breaks. I think there is a membrane here. Yeah.
Yeah, Purva, I think you
Yes.
should go for restaining if you want to be more comfortable. and
Yes,
use a
sir.
yellow
And there is a membrane there. I'm going to
Yeah.
pick it up.
In the papillomacular bundle, there is a small,
Yeah, I have to be very careful here. Yes. So it's important to identify these membranes and peel them. Yeah, there you go. Second membrane peeled. 1 second. Yes. I'm going to carefully pick on this and see if this is also a membrane. Looks like this seems to be a fold, but one can never be sure because of the chronicity of the membrane and the underlying retinal thinning.
I think you can just leave it there.
Yeah. Yes. So let's restain. Some backflush, please. So I'm just going to get rid of these oozers a bit. Yeah. Yeah, I can see one more membrane. Peel island. Can I have my usual forceps? Peel scraper. Yeah, this is definitely a membrane here. Forceps. Can also see this circular. This problem is this might bleed. Yeah, there it is. Yeah. These planes are a little difficult to identify, but let me see. Looking at the OCT, it was looking as if this whole membrane will come off very easily, but apparently not. It's got multiple layers. Yeah. So now I'm going to use a scraper again. Yeah. ILM. It's a multi-layered ERM. Yeah, it's better to peel as to the extent possible and leave the rest. I can see the retinal vessels are much below this. So yeah, this is not retina, what I'm pulling at, because the vessels are below it. But it's definitely causing a lot of oozing from the bed. So I'm going to trim it with my cutter. I'll go back to my wide angle, use back flush and trim the membranes. Visco?
Can you put the tricot more to
Yes, sir.
stain?
I'll do that.
I think ILM would be a better stain. You will understand, you will get the better plane.
Yeah. So back flush.
Yeah, brilliant blue would be a better stain, I think.
Yes. Light, please. Yeah. Invert, please. Don't. Yeah, I think BBG is a better stain for this. BBG. Yes. Yes. Now some ILM has got stained. Luckily for us. Now I'm going back in, trimming some of that. No, I would like flat lens. I have found a good stain at the inferotemporal arcade. So I'm going to use that and use the ILM to as a handle to peel the ERM if there is any residual ERM. Okay, ಬರ್ತಾ ಇಲ್ಲ focus. Standard ಮಾಡಿದೀರಾ? Have we removed the biome? ಏನಾಯ್ತು? Yeah, there it is. Okay. Okay, fine. Light ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಮಾಡ್ತೀರೇನಾ? Okay. Yes. So I'm going to use this handle right here, this semicircular ILM staining. Is going to be a sticky ILM. There. Pre-stain.
Because of the folded retina, these islands sometimes may not come as a sheet.
Yes.
I think in these cases, you can just peel on the fovea and then probably not arcade to arcade may not be required.
Correct. Correct. Also true. Let me see. Not happy with these forceps, sister. Can I have my usual forceps? Yeah. God is kind, no? He's
Oh, wonderful.
It's not about-
finally.
Not about God being kind. Your persistence is paying now.
I think that was a good idea by Sachin sir, starting from the fovea. My usual one, the end grasping one. Okay. This is retina, so I'm going to leave it alone.
Excellent job, Dr. Apurva.
Thank you,
Very
sir.
nice. It's
Thank
coming actually. I think you can just clear around the fovea and leave it.
Yes, yes. Pre-stain.
I think that papillomacular bundle is already folded too much. I think there, I think it'll be very difficult for you to
Yes.
get the island, right?
Yes.
Besides that, the long-standing traction has caused a sciatic type of a retina.
Yes.
Correct,
So it's
correct.
always going to be a bit tough, and you have to be very careful not to end up doing a break. So
Correct.
So relieving it central traction and minimal of it should suffice in such cases, because
Yes.
otherwise, I think we see a small membrane ILM folded
Yes.
over papillomacular bundle. Even if you relieve that, that should take care.
ERMs always behave like this. Sometimes, they look very easy on OCT, but they'll have layer by
1
layer.
minute, ma'am. हो गया बस. Yeah.
Fantastic.
That's a great job. That's a beautiful job.
Thank you. Yeah.
I think that superior part ILM, there was ERM also stuck to that some amount. Now you can see very nice
Yes.
released fold.
Yes. This was actually beguiling on the OCT because if you look at the OCT, it looked like a nubbin of ERM that's just going to come very easily, but it turned out to be a multi-layered ERM.
No, in fact, if you look at it, Apurva, you can look at that the inner structures of the retina were all distorted.
Correct,
So that
correct.
speaks about chronicity, and you should be anticipating a sciatic type of a retinal layers where you are tackling such membranes.
Correct.
So in
Yes.
such cases, most of the times, everyone has to struggle through this.
Yes, true. So I'm not going to be too acrobatic and try to achieve an arcade to arcade peel. See how thin the retina is. It's like,
Apurva?
yes, sir, we'll shift,
Yeah.
we'll shift, we'll
Yeah,
shift.
we'll shift now?
I think the business part of it is over.
Yeah, you've demonstrated a wonderful.
Excellent surgical
excellent
demonstration, Apurva.
Thank you, sir.
Very nice.
So,
Yeah. Now, shall we go ahead with the other remaining surgery talks?
Yes, please.
Yeah,
please.
yeah. Thank you very much.
So
Thank
here
Thank
is a big round of applause for you, Apurva.
Thank you, sir. Thank you so much. Thank you. So nice of you all. Yes. Let's revert to wide angle.
One last question. Are you putting gas in this?
I don't think we need to put either a gas or any tamponade.
Can we have the lights, please? Lights. Dr. Aniket, can you just request them to put on the lights? So before we head on to the next talk, we have a pleasant task of honoring two doyens in ophthalmology. I would like to call upon Dr. Namrata Sharma Madam and Dr. Santosh Honavar sir. So firstly, I asked who is the senior. Then I got to know that Santosh Honavar sir is 6 months senior to Dr. Namrata Sharma. So stage lights on, please. Request all the directors to please come up on the dais. Dr. Santosh Honavar sir, trained at RP Center and Wills Eye Hospital, Philadelphia, established ocular oncology at LVPI, was the associate director of LVPI and established the residency program. Presently heads the oculoplasty and oncology at Center for Sight, CFSC Education, awarded the Shanti Swarup Bhatnagar Award by Government of India. He is giving a talk. Meanwhile, by default again, it's none other than the Majesty Dr. Namrata Sharma Madam. Fellowship from Moorfields Eye Hospital in London, UK, the chairperson of Scientific Committee of All India Ophthalmic Society, the first Indian to be inducted as the Director at Large International Member in the Cornea Society International of USA, inducted as the Council Member of Asia Cornea Society from India in the year 2024, the first Dr. Paul Dubord Award for International Eye Banking by Global Alliance of Eye Banking Association, featured in the 2023 Stanford list of top 10 highly cited ophthalmology researchers in India, and in top 2 scientists in the world conducted by Stanford University. She is amongst the list of 100 top powerful women ophthalmologists in the world and top 100 most influential ophthalmologists 2022 by Asia Pacific Journal of Ophthalmology. With this, we would like to honor Dr. Namrata Sharma Madam with the Global Excellence Award for Ophthalmology. Ladies and gentlemen, please give her a big round of applause, please. We have Dr. Santosh Honavar sir here. Dr. Santosh Honavar sir, please come up onto the dais. So he's the man awarded with the Shanti Swarup Bhatnagar Award by Government of India, Jerry Shields Award by Asia Pacific Academy of Ophthalmology, and the only Indian to receive Lifetime Achievement Award by American Academy of Ophthalmology in 2019, and Honorary Fellowship of Royal College of Ophthalmologists. Is also the top 2% of world researchers and tops the researchers in ophthalmology in India. Ladies and gentlemen, please give a big round of applause for the Global Excellence Award constituted by MM Joshi Eye Institute to Dr. Santosh Honavar. Have 2 more talks left before going for lunch. Request Tuti to please take over.
Thank you so much, sir and ma'am. I would now like to request Dr. Partha Biswas, sir, to come up on stage for his talk, and would request the chairpersons to briefly introduce.
Dr. Partha Viswas, the President-elect of All India Ophthalmic Society, Medical Director, Trinetralaya, Director of Netralayam. He has bagged best overall papers 8 times, best video awards 3 times. And he has awarded Indian Intraocular Refractive Society Gold Medal, VOA Gold Medal for a explanatory work in the field of ophthalmology in 2013. Dr. D.K. Bose Gold Medal Annual Bihar Ophthalmology Conference 1991. The Hussein Gold Medal Pune, Patna University in final MBBS examination. Dr. and Mrs. T. Agarwal Gold Medal, IIRS, New Delhi. Professor of N.D. Oration Award at Vidarbha Ophthalmic Society, Oration at Annual Conference of Odisha State Ophthalmology 1917. Here I present the Golden Man. Dr. Partha Viswas, he is going to speak on hard cataract, management of hard cataract.
I wish to thank MM Joshi Eye Hospital from the bottom of my heart for giving me this opportunity to be here. I also have had the rare opportunity to give a lot of excitement in the OT and in the hall during my life surgery. And thank you for bearing with me. The topic allotted actually is post-refractive surgery, phacoemulsification, and that's what I'd like to speak on. And this is something that is going to happen very, very frequently, and we need to understand the challenge that we have, and it's a unique challenge for all cataract surgeons, because a refractive surgery patient who has undergone refractive surgery and has been independent of glasses knows that this is what life is, and thus unrealistic expectations is the rule even when cataract has set in, and this is what he expects, that he'll be without glasses even after cataract surgery. So where is the other challenge? It's the low accuracy of our current biometry formulas, and which have to be changed, and the refractive surprise is something that we have to take into account. For if it is a post-myopic refractive surgery that has been done, so the expectation would be a surprise of hyperopia, and also if it was a post-hyperopic refractive surgery, then it would be something that you would expect a myopic shift in a post-operative surprise. So what are the sources of error? The sources of error are the keratometry, and we know that the holy grail of keratometry is the measurement taken at central 2.5 to 3 millimeter zone, which has been flattened after the keratorefractive surgery. And what we assume that the spherocylinder cornea leads to overestimation by nearly 15 to 25%. And of course, the relation between the anterior and the posterior cornea has been altered by the KRS, and therefore 1.3375 nowhere is the rule, and it is fallacious. So it's an error in the formula. The new generation formulas are important and utilize the relationship between K and ACD to estimate the ELP. After a myopic KRS, these formula predict false shallow ACD, and that leading to an anterior ELP. So this is an underestimation of the IL formula and the surprise. So what are the formula that we use right now? And the ACRS online formula is something that is very much available, and multiple formulae are used to calculate the IL power in these patients who have undergone keratorefractive surgery. Now, there are quite a lot of relevant studies as well as meta-analysis to which we allude to, and it's important that we improvise certain steps in the cataract surgery of these keratorefractive surgery patients as well. So the intraoperative aphakic calculation, this again has a very big importance, and even a simple on-the-table retinoscopy on the aphakic mode of a patient who has undergone the lens extraction, the surgeon waits for 3 minutes while the best optometrist does a quick calculation on table with the aphakia in place, calculates what could be the possible lens power, and then places in the lens, and that lens is usually not too much beyond what our expectations would be. And of course, the intraocular pressure variation and the patient fixation, the pressure of the speculum, these things have to be taken into account. So this is my optometrist who is quickly doing an aphakic calculation while we have all the formula in place with the biometry. So what is the role of preoperative counseling? Huge, very important, and it is to tone down the patient's expectation to whatever realistic results that we can give. And the intraoperative challenges, especially if it is a RK for phacoemulsification, it's very important that the incisions of the cornea are not tampered with. So if it is a 16 incision or an 8 incision of RK, it's very important to go a little scleral, not tamper, and leave that bridge between the two incisions so that the incisions are not increased. Also, it's important that even the side port incision at times have to be a little scleral, and preoperative counseling is very important because these patients can land up with some amount of astigmatism, which the patient has to bear with. Now, let me show you a quick mystery case. And this was a 43-year-old female who presented with her husband with a diminution of vision, had grade 2 cataract, and no medical or surgical history. We planned a phaco with IOL. Slit lamp did not reveal any keratorefractive surgery. So we did biometry calculations, but God's grace, she comes back this time alone and tells that she had a laser treatment done for her. And that was 19 years ago. So we did a pentacam in this particular patient. We do not do a pentacam for all patients who are undergoing cataract surgery. And this is what the pentacam revealed. There was definite evidence of a keratorefractive surgery. So the ASCRS online calculator, and we calculated the power, 12.17 is what it gave. But when we did the on-table retinoscopy by the optometrist, he insisted that the power of the lens should not be anywhere 12 or 13. He insisted on 15. So we give a 15 diopter lens for this patient and look at the postoperative refraction. So it was just 0.75 with 1.0 at 90 degrees. And this just shows that a manual aphakic refraction during the table at times can save you from a lot of difficulty postoperatively. So post-LASIK phacoemulsification, again, flap and the hinge has to be taken into account. I'll just take 2 more minutes, please. And it's very important not to disturb the flap, because if the edge of the flap is disturbed, it can undergo a lot of difficulty. The post-ICL phacoemulsification, again, the calculation of the IOL power is not a difficulty, because you just calculate whatever IOL power the biometry or the optical biometry gives you. The explant of the ICL is important prior to the phacoemulsification. We have a clip of the explant and the implant, but I think we might, if I can run the video quickly. So this was again a difficult case. I'll quickly run the video and shorten it So you can see that there was synechia there, and the patient had the ICL in place. So we understood that this is not going to be very easy a surgery, and there would be difficulties. So we took off the synechia, and after taking off the synechia, we had the ICL there. And then removal of the ICL going hand over hand. It's not a very difficult aspect, and it can be done well. It removes the ICL, the ICL comes out. But remembering the fact that there was synechia here, so it's important to remember that the capsulotomy might not be very easy, and that's what happened. So the capsulotomy ultimately ran out, and not in one place, but in two places. So we have an intumescent cataract with a capsulotomy run out in two places. And this is what is happening. Now we have this patient, but what we discovered is there's a big, thick plaque that is sitting on the posterior capsule. Therefore, this patient, during the VR surgery, possibly had a lens touch. And so we place not the single piece, but the multi-piece lens in the sulcus, and it stays there. But what do we do about this plaque that is there? So we go in with the MVR. I'll just stop. We go in with the MVR and take off the central opacity with the vitrector, and that ends the surgery. The patient recovered with about 624 vision and N12, which is quite good in such cases. So thank you very much for your patient hearing.
Thank you, sir. The next speaker is Dr. Namrata Sharmana.
Ladies and gentlemen, we have only 10 more minutes before we break for the lunch. So before that, we finish Dr. Namrata Sharma, madam, as she has a flight to catch. Tomorrow they have to be in Delhi for some important meeting. So we'll finish quickly Dr. Namrata Sharma and Dr. Prafulla Marana, and then we break for lunch.
So thank you. And
Just 10 minutes.
I'm clearly standing between you and your lunch. So this is DALC in special situations of keratoconus with no financial or proprietary interests. And there are various techniques, but the gold standard remains the big bubble technique for keratoconus. And classically, what was described was the Mally's technique, in which the air bubble is instilled in the anterior chamber. A 400 micron groove is made over here. Lamellar dissection is then done from limbus to limbus, and subsequently the viscoelastic is injected. And then trephination is done after suturing the incision. And once you trephinate, the excision of the keratoconic cornea is done. So you are not at the Descemet's membrane level, but you are at the near Descemet's membrane level. So this is the safest technique to do. However, when Dua's layer came in between the Descemet's membrane and the stroma, such as shown here. So if you have a bubble above it, it is type 1 big bubble. If you have a bubble below it, then it is type 2 big bubble. But having said this, big bubble technique is the technique go to for keratoconus. So in this, the insertion, the partial thickness trephination up to 60% depth is done, followed by the air which is injected in the supradescemet's membrane compartment, and then the nick is given in the overlying stromal layers. So actually you can see the utility of the intraop OCT microscope, where you can see the Descemet's membrane marching towards the overlying stromal layers in a live show right before you, and you don't have to imagine it, but you can actually see it happening. Then viscoelastic is injected, and so like a kangaroo's pouch, the Descemet's membrane drops down, and then you graze or you excise over the Descemet's membrane and over the viscoelastic cushion. So this is the bare Descemet's membrane which is looking at you. You're still extraocular, not penetrated the anterior chamber at all, and a full thickness donor cornea is then placed, and 10-0 monofilament sutures are applied. So this is the pre and the post-op picture of the DALC in keratoconus. Now, sometimes what can happen is there can be perforation, like when the excision was being done here, there is a perforation. Aqueous comes out from here. So in these cases, when you have perforations, you can still do DALC, can leave a little bit of tissue over there. So this you can see will seal the perforation temporarily. And again, one doesn't have to convert to a full thickness graft, but deep anterior lamellar keratoplasty can be done. Now, in healed eye drops also, earlier it used to be said that you shouldn't do DALC, but we've shown that you can do if you have a intraop OCT microscope. So you do a manual dissection. You can see that there is a scar which is present here. So after doing trephination, do layer by layer manual dissection. As soon as you come near the scar, you go a little anteriorly. The scar is somewhere over here. You go a little anteriorly, as can be also seen here, and change your level of dissection. And then subsequently, the dissection is done, as can be seen here. And the Descemet's membrane and with little bit of stroma is still there, but that doesn't matter. It is off the axis. It's not there in the axis, and the graft is then sutured to the host. Now, this is to show the DALC healed head drops pre and post-op, and the central part of the cornea is quite clear. Then you have peripheral corneal ectasia such as keratoglobus, and it becomes a little tricky because the cornea is thinned out. It is keratoconic. There are large cones which are present. So what we've advocated is the tuck-in lamellar keratoplasty in these cases. So basically we do dissection with a full thickness cornea and a flange which is present, and tuck this flange into the peripheral part of the cornea which is thinned out. You can do it 360 degrees or can do it just sectorally in one sector. So these are the results pre and the post-op, which are quite good. So if you see the video, you do partial thickness trephination first, do the layer by layer dissection as being done here, and then subsequently make a pocket all around, which is 360 degrees from one end to the other. And after making the pocket, the donor cornea is taken, it is trephinated, and this 0.5 millimeters of the flange is then removed, because otherwise it will become very thick and will not fit into the pocket. Now, after fitting this, the AC paracentesis is done so that the ectatic cornea falls down, becomes flat, and then subsequently this thickness, this cornea which had been previously dissected with the peripheral flange is dissected into the pocket that you had already created. And because it is keratoglobus, so the periphery is also thinned out. And this is after suture removal with very good results. So this is the pre and the post-op picture of the tuck-in lamellar keratoplasty. This is just to show when you have pellucid marginal degeneration. So you have only this part of the cornea which is thinned out inferiorly. So your flange is also inferior because this part of the cornea is all right in thickness. So again, the sutures are placed in such a way that the flange is tucked inside the peripheral pocket of the thinned out cornea which was present. So this is to show the half, we call it half tilk, which was done for pellucid marginal degeneration. You can see the flange here. This patient also had cataract, and so the cataract surgery was also done. And the patient had good vision of 6/9 post-operatively. Again, these are just pictures to show that in post-radial keratotomy ectasia also you can do tuck-in deep anterior lamellar keratoplasty with very good results. And in post-radial keratotomy and transverse keratotomy ectasia and healed head drops also, this procedure can be done. And the visual acuity does improve from counting fingers to post-op 20/40. And this is to show the pentachem of the same patient. And this is the fellow eye of the same patient which had healed head drops. So to conclude, DALC is possible in almost all cases of keratoconus and does give optimal visual results. And although the big bubble DALC is the gold standard, but it does have a learning curve, and intraoperative OCT is required to refine the technique further. So thank you very much for your kind attention.
Thank you,
madam.
Namrata madam, for that wonderful talk. Thank you very much. We have last talk before we break for lunch is Dr. Prafulla Kumar Maharana. He is the MD senior resident from, senior residency finished from cornea and refractive from RPC AIIMS. He's additional professor now, and he's also secretary of Delhi Ophthalmic Society, has published more than 395 Google Scholar and 163 PubMed indexed papers, 50 chapters in national and international books. Over to Dr. Prafulla Maharana, please.
Thank you so much. And if ma'am was standing clearly between you and lunch, I think I am blocking the lunch for you people. So I'll keep it short. So what are the challenges of doing phacoemulsification keratoconus? There are three major challenges: biometry and surgical problems like visualization, and then IOL and post-op rehabilitation. So I'll stick to the surgical challenges. So little bit about biometry. So which is the best formula? And this is an article published in AJO, and you can see out of all the formula available, the CAN formula that has the least amount of error, residual error. So that is the best. Barrett's true K also holds true. Modified CAN formula is nothing but an AI generated formula. And if you are using it, which is an online program, you should always remember this addition, that this modification to be done. So these are few of the cases. I'm not going to the details of that, but overall the formula really works well. We have done it in almost 4 of our cases, and the results were excellent. Now coming to the surgery, I'll just go through the briefly the important steps that you should remember. Remember, most of these cases, the cornea is thinned out. So your incision should be near limbus, and few surgeons, they prefer corneoscleral tunnel. Trypan blue is a must in all your cases. Always start rexis from which is away from the cone area. It should be from a clear area, and use rexis for some hydrodissection. Yes, you should do it all cases. Most of the cases are not that hard. Even if it is hard, you can easily manage it because phacoemulsion is not a challenge. The main challenge is your visibility, because the depth perception is really affected because of the cone. It was a fibrotic cataract. So, but after little bit jiggle, this fibrotic peripheral cortical cataract came out. The rest of the steps are similar to your routine phacoemulsification. The next video shows you one. Here, I would like to show you one important part. As you can see, distortion of the instrument. This is what I wanted to show. You can see when the rexis is being attempted, just see here, this is the area of cone. When the instrument passes there, you can see the instrument getting distorted. So that is one of the main problem when you are operating in cases of keratoconus. So that's why always use a rexis for SEP. If you use a capsulotome and somehow you leave the flap here, then it becomes very difficult for you to subsequently manage. The rest of the steps are similar to the first case that I showed. And this is one important phenomena. Most of the time, keratoconus may be associated with dilator muscle atrophy. So the moment you go in with your phacoprobe, there will be dilatation. The moment the chamber becomes shallow, there will be constriction. We call it as a breathing pupil. So that you have to be careful. Since you are making a limbal incision, conjunctival ballooning may be there, and you have to take care of that. At times, the bag volume is very large. So the pieces may be moving here and there. What you can do is you can use some viscoelastic cushion to take care of that, and always be worried about some missing pieces. Even if you feel that all the pieces have been emulsified, you may suddenly find one piece coming out from the periphery. So you have to take care of all this. You have to keep all this thing in mind. This is a problem of corneal incision. Never attempt a corneal incision. If you make a corneal incision, as you can see, the cornea was quite thinned out here, and then you may have to put suture in the post-op period. So this is a brief chart showing what are the difficulties and how you can take care of that. Light scattering, depth perception, presence of scar due to high drops, cornea-cornea junction, ectatic and normal cornea junction, and loss of contrast are the difficulties. How you can take care of that? Use a viscoelastic properly on the corneal surface, trypan blue, and one study suggested you can put an RGP lens and do the phaco. Corneal incision, again, avoid the cornea which is scarred, make an incision near the limbus. And if you are little bit doubt, always put a suture or glue. These are the difficulties that you can take care of. This is the study I was telling of. OI et al. They produced this study where they use a RGP lens intraoperatively to improve the visibility. This is a Jared protocol. You can follow that. And this will help you in deciding whether to go for toric IOL or not. Whenever you are considering toric IOL, please ensure that the patient is not tolerant to contact lens. If the patient was having good vision with contact lens, toric contact lens, then it's a RGP lenses, then the patient will never be certified in the post-op period. So before I conclude, I'll just like to share one case with me. This was a patient with a pediatric patient referred to me with a diagnosis of keratoconus and cataract for cataract surgery. But when we did the fundus evaluation, you can see he had a classic feature of Lawrence-Mood-Biddle syndrome with obesity, lid problem, and retinitis pigmentosa and optic disc pallor. So the thing to remember that at times keratoconus with cataract may be associated with other syndromes. So do a thorough examination before jumping onto the surgery. And proper patient counseling is very important. Most patients, in spite of doing a good job, the best vision is between 618 and 624 with some difficulty. And some people may need even contact lens post-operatively. That you have to counsel beforehand. This is an IOL IC8 Apthera where they had a central hole that may neutralize that scattering of this cone. And the results are good initial results. It may soon come into the market, and we may be able to do that. And for this talk, I would like to acknowledge Dr. Priyadarshini, my SR, and Dr. Namta Sharma, who is my unit in charge. And I am the current secretary of Delhi Ophthalmic Society. Thank you very much for inviting me here. And I would like to invite you all to our annual conference, which we are going to from 13 to 15 June 2025. With this, I will conclude here. Thank you, Joshi Group. Thank you, Krishna Prasad sir. Thank you, Dr. Srinivas, for inviting me. And I'm sorry that I'm leaving early. I would have loved to stay the whole day here, but there is some meeting for APAO tomorrow, so that's why we have to leave. Thank you so much.
Thank you, Dr. Prafulla. Thank you very much for that interesting talk. I now request Joshi sir to please present him Prafulla Marana, a Young Ophthalmic Leader Award. Congratulations. Request Guru Prasad sir to please join us. Dr. Prafulla Marana, request Joshi sir to please present him of the Young Ophthalmic Leaders Award, please. Thank you. Thank you very much. Thank you, Dr. Prafulla. Hope to see you back again. Okay, thank you very much. We'll break for lunch. And before that, Stuti, request her to please.
I would like Srinivas Joshi sir to please hand over the memento to all our chairpersons and panelists of the previous sessions. Dr. Shankar Goda Patil sir, Dr. S.V. Koti sir, Dr. Shravan Pandit sir, Dr. V.S. Sajjanar sir, Dr. Mahesh Bhajantri sir,
With that, we close the pre-lunch session. I request all of you to kindly take your